So welcome to Hall B, and this is the poster presentation awards, and we'll have 6 sessions, and the judges for the first session are Dr. Ashok Chaudhary and Dr. Manav Vadhavan. So may I request you to start the proceedings?
Yeah, good evening. I think Dr. Manav, should I start or you?
Yeah, please, Ashok, please carry on. Please do the honor.
So, I think the first one is an interesting topic of outcome liver transplant recipients with COVID-19. And the presenting author is Dr. Soumya, and he's from AIG Hospital. So, I hope we are allowed only for 5 minutes the presentation as well as 2 minutes for the questions.
Good evening, sir. Myself, Dr. Soumya. Can you all hear me, sir?
Yeah, you are audible. Please start.
Yes, sir. I'm working as a junior consultant in the Department of Hepatology at AIG Hospital, sir. So, I'll be presenting a meta-analysis done by Dr. Anand V. Kulkarni et al., which studies the outcomes of COVID-19 infection in the liver transplant recipients and compare these outcomes in the non-liver transplant patients. Coming to the background of this study, we all have seen that the outcomes of COVID-19 can be affected by presence of comorbidities like hypertension, diabetes, liver disease, kidney disease, and obesity, and pre-existing pulmonary disease. In a earlier meta-analysis conducted by Dr. Kulkarni et al., it was proved that pre-existing liver disease, except in the presence of cirrhosis, COVID-19 does not have an adverse outcome. However, the COVID-19 can worsen the cirrhosis and outcomes. The transplant programs had come to a standstill ever since pandemic transiently, but however, it was observed that there was increase in the waitlist mortality globally. So the transplant centers have initiated the solid organ transplant globally. However, the presence of comorbidities and chronic immunosuppression may increase the risk of severe COVID-19 among the solid organ transplant recipients. The effect of COVID-19 on the liver graft injury and the liver transplant in liver transplant recipients is unclear. So it is crucial to understand the clinical course management and outcomes of the COVID-19 in these patients. So aims and objectives of this study were to assess the clinical presentation. To answer these questions, we did the study to assess the clinical presentation, management, and outcomes of COVID-19 in LT patients, and to compare the outcomes of COVID-19 in LT with those who didn't undergo transplant. The objectives of this study, the primary objective was to assess the incidence of mortality among the LT recipients and compare the all-cause mortality with the infected LT and non-LT patients. Secondary objectives were to compare the effects of early and late COVID-19 infection. As defined, early infection was defined as within 1 year of the transplant period, and to assess the clinical presentation and course of COVID-19 among LT recipients, and to study the effect of graft dysfunction and acute rejections due to COVID-19 infections. So it's a meta-analysis. We followed the Moose guidelines. We used the electronic database and searched for the words COVID-19, SARS-CoV-2, and liver transplant. We got 294 articles, of which 122 were duplicate. Review articles, guidelines, recommendations, protocols, and the articles of other languages were all excluded. So out of the 172 abstract screen, only 57 full text articles were considered. And out of these 57, the articles having less than 10 participants were also excluded, and a study which had a database from the same patients were also excluded. So totally 18 studies were included for the systematic review. And the case control and cohort study bias was assessed by NOS scale. Studies with NOS score of less than 7 were excluded from the sensitivity analysis. The publication forest plots were generated to present the pooled estimates. The publication bias was assessed quantitatively by Egger's regression intercept test and qualitatively by visual examination of funnel plot symmetry. Coming to the results, there were a total of 1,522 patients, of which 68.5% were male, and the mean age of these patients was 60.38 years. The most prescribed drug was HCQS, and the mean time for development of COVID-19 infection from the transplant was 5.24 years. Coming to the symptoms of COVID-19 among the LT recipients, the most common symptom was fever, which was seen in 49.7% of patients, followed by cough and dyspnea, and GI symptoms were observed in 27.26% of patients. Of these 18 studies, 4 studies did not report the age and gender of the patients, and 5 studies did not report the symptomatology of the patients. And complications of COVID-19 among the LT transplant, LT recipients is as listed in the chart on right-hand side. Severe disease as defined by requirement of non-invasive or invasive ventilation or ending in mortality was observed in 22.8% of patients, and AKI as defined by more than 0.3 elevation in the creatinine from baseline within 24 to 48 hours of infection was observed in 33.22% of patients. Out of these patients, 55% of patients underwent RRT. Thrombotic complications as defined by DVT or pulmonary thromboembolism, MI or stroke were observed in 5.75% of patients. Secondary bacterial infections were seen in 11.6%, fungal infections in 2.5%. The hospitalization rates were comparatively more among the LT recipients than non-LT patients. This might be because of the patients taking a preventary measure in getting admitted to a healthcare setting. However, the ICU admission rate and the ventilatory support rates were comparable in both the groups. Elevated liver chemistries were observed in 21.6% of patients. Graft dysfunction is seen in 2.3%. This is a forest plot.
You have to be faster. You have only 5 minutes. You are already covering. Try
Okay,
to finish in another 1 minute.
Okay, sir. This is a forest plot showing the incidence of mortality among the 17 studies which reported the mortality of COVID-19 among the LT recipients, and the cumulative mortality was 17.4%. And this is at 95% confidence interval of maximum value of 19.6 and 15.4% as the minimum value of mortality. And this is a forest plot describing the mortality rates among the LT and non-LT recipients. Here we can see that the diamond is lying on the line of null effect, indicating that there is no significance of mortality among the LT patients and non-LT patients in terms of mortality in COVID-19 infection. And on the right side, we can see the comorbidities among the LT recipients and non-LT patients. LT recipients had more of diabetes. However, non-LT patients were observed to have more of cardiovascular and pulmonary disease. Hypertension and kidney disease were equal among both the groups. Coming to the immunosuppression, tacrolimus and mycophenolate mofetil were the most commonly used immunosuppressants. 8 articles reported the change in the immunosuppression, 55% in 55% of the patients, and detailed changes of the immunosuppressions were provided for 56% of patients. And during the infection, CNIs were modified in 49.6% patients, and MMF was modified in 42% patients. MMF was associated with higher risk of mortality in one of the study. However, tacrolimus reported to prevent mortality on multivariate analysis in one study. However, none of these studies reported any effects on the baseline immunosuppression and change in the immunosuppression during in terms of outcome or mortality or disease severity. The study qualities were assessed by the funnel plots. The plot A describes there was no publication bias seen among the 17 studies reporting the mortality. And in the plot B, we can see that there is no publication bias in comparing the mortality between the LT and non-LT patients. In the plot C, we can see that there is a publication bias in the 6 studies that are reporting mortality based on timing of the infection, although there was no heterogeneity in this group. The study, and in the plot D, we can see there was no publication bias reporting the graft dysfunction also. So coming to the take-home messages, this meta-analysis demonstrated that there was comparable mortality in LT and non-LT COVID-19 patients. 23% of the infected patients developed severe disease, while 72% of the patients were hospitalized among the LT recipients. Only 16 required ICU care. Even though the hospitalization rates were higher in LT group, the outcomes were similar in both the groups. The cumulative incidence of graft dysfunction was 2.3%, and most of the patients were on tacrolimus or MMF before the infection. The most commonly modified immunosuppressant was CNI. Coming to the limitations of the study, the effects of change of immunosuppression and the effect of triple immunosuppressants on the outcomes of the COVID-19 infection were not studied in this analysis. So I conclude my presentation, sir. Thank you.
Thank you, Dr. Soumya. Ashok, if you may allow, I think we have already taken 7 minutes. So no more questions. If you have one question, you can ask.
No, I think we should not, because time is short. You have to stick to the time.
Absolutely. So we should stick to time. Let me invite the second contender in this. The second abstract is titled HBsAg seroconversion may not be durable event in the course of chronic HPV infection in adults. The presenter will be Dr. Pallavi Garg. She is a senior consultant in gastroenterology in Max Super Specialty Hospital. Dr. Pallavi, please start your presentation and try to stick to 5 minutes which have been allotted to you. Dr. Pallavi, you are mute.
Good evening, sir. My topic is HBsAg seroclearance may not be a durable event in the course of chronic hepatitis B infection in Indian adults. So the background is HBsAg seroclearance with or without appearance of anti-HBs antibody is considered to be the functional cure. It is a proposed definition of functional cure in chronic hepatitis B infection. However, the available data is sparse and there are multiple controversies in it. The data is very scarce on the durability of this HBsAg loss. And probably this is the first paper from India. So there are no consensus on the endpoint of treatment of chronic hepatitis B infection. In this study, we aim to find out the frequency of HBsAg loss among the Indian patients with chronic hepatitis B infection. Also to study the factors associated with hepatitis B surface antigen loss and to understand their clinical course in patients who have cleared hepatitis B surface antigen. This is a retrospective analysis of data which we collected from our patients who had a follow-up of at least 5 to 10 years who were suffering from chronic hepatitis B infection. The exclusion criteria is patients less than 18 years of age, patients with co-infection with hepatitis C, HIV infection, patients with hepatocellular carcinoma, or patients who cleared their hepatitis B surface antigen post-liver transplant. So out of our study population of 270 patients, 15 patients, that is 5.5%, had hepatitis B surface antigen loss. And the baseline characteristics of these patients were the median age was 49.5 years, out of which 12 were male. 4 out of 15 patients were E antigen positive. The median baseline ALT was 41.5. HBV DNA was 1.4 into 10 to the power 5. Fibroscan showed a liver stiffness of 8.05 kPa. Out of 15, 3 patients had spontaneous hepatitis B surface antigen loss, and the remaining 12 were nukes induced. Out of 15, 5 patients had liver cirrhosis, of which 2 were compensated and 3 were decompensated cirrhotics. Of the 12 patients who were on treatment, 10 had received entecavir and 2 were on TAF. So the clinical course of patients who had surface antigen loss, out of 15, 7 patients had developed anti-HBs of more than 10 milli-IU. And the duration required for HBs-AG detection to HBs-AG loss was a median of 60 months. The duration for seroconversion from loss of hepatitis B surface antigen to development of anti-HBs antibody was 8 months. Of 15, 5 patients had seroreversion, accounting to 33%. And the predictors for this seroreversion was, in 80% of the patients, it was stopping of the antiviral medicines, and none of the spontaneously cleared patients had seroreversion. So of the 270 patients, 15 had loss, of which 12 were on treatment. Of the 15 patients, 7 patients had developed anti-HBs, accounting to 46%, of which 2 had seroreversion. And of the 8 who did not develop anti-HBs, 3 had seroreversion. What I'm trying to say here is there was no significant difference in the patients who had developed anti-HBs and who did not develop anti-HBs. The rate of seroreversion was approximately more or less the same in both the groups. In our study, the rate of seroclearance was 5.5%, which correlates well with other studies done by Lok et al. In hepatology, which was published in Hepatology Communication in 2020, Alawad et al., which was published in Clinical Gastroenterology and Hepatology, and Tuber et al. Seroreversion rate in our study was 33%, which is slightly higher than the other studies, which quote up to 2.1 to 18%. The proposed reason for higher seroconversion rates in our study is probably this is a different population. All the studies described here were from the Western population. This is probably the first study with Asian, with Indian population. The virus is different. The genotype of the virus is different. And yes, of course, because HBs-AG loss is a rare phenomena, the sample size is of course small, and particularly it is smaller as compared to the other studies also. So to conclude, I would like to say that hepatitis B surface antigen seroclearance is not durable in 1/3 of the adult patients with chronic hepatitis B infection, especially if it is induced by nucleoside analogs. Patients who achieve hepatitis B seroclearance, especially on antiviral, should be followed up closely. Thank you.
Thank you, Dr. Palvi. One question for you. Any
Sure.
of these patients, any of these 15 patients, were there any immunosuppression of any sort for you?
No,
You
sir,
told us they were not liver transplant recipients, but any other reason, arthritis, rheumatoid arthritis, or any
No, sir.
immunomodulatory?
None of the patient was on immunosuppression. It was a part of the exclusion criteria.
The ones who developed anti-HBs antibody, did you monitor the titers of the antibody also? Were they more than 100 in any case?
No, sir. We monitored the titer. Out of the 15 patients, 7 had a titer of more than 10. And barely 2 out of this 7 had a titer of more than 100.
All right. Ashok?
Yeah, do you, why you can say that it is having, some having titer of 10 and some having had titer of 100?
So we monitored the titer.
No. What is the reason behind having such a high titer in few and less titer in few?
So that is difficult for me to answer.
No, it's okay. Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you, Dr. Manav and Dr. Ashok. We'll go on to the next session B. Dr. Jyotimani and Dr. Yatu, request you to please start the proceedings. Thank you.
Hi, good evening. The next presentation is by Dr. Raghu Rai Sharma. The topic is on chronic ethanol consumption exacerbates high cholesterol, high fat diet, induces diabetes and fibrosis in C57BL 60 mice in 8 weeks. This is from CSIR IIM Jammu. Please take 5 minutes.
Good evening, dear judges. Is my slide visible?
Yes.
Good evening, everyone. Today I am here to represent my research work, chronic ethanol consumption that exacerbate high cholesterol, high fat diet, induced steatohepatitis and fibrotic changes in C57 mice in just 8 weeks. As we know,
Sorry, can you
both
make
the
it full
diseases are...
screen, please? Make it full screen. Please see a small screen.
Just wait. Text bar. Full screen.
At the bottom, there's a sign which shows full screen. Just on the left of the minus sign.
Just wait.
We're just running out of time, actually.
Sorry, sir, but new share window. Is it full screen now?
Not quite, but anyway, just present. You don't have much time, actually.
I am working on alcoholic steatohepatitis along with the non-alcoholic steatohepatitis. Both are the chronic liver diseases at present, and both shares overlapping histological and clinical features. As the prevalence of these diseases are increasing worldwide, and we are trying to understand the various pathophysiological conditions that are evolving at the preclinical level, and the main focus on the research is on discovering novel therapeutic targets by utilizing various in vitro and in vivo models resembling human conditions. We have hypothesized the multiple hit hypothesis given by Garnetti in 2016. We have included the alcohol consumption in that hypothesis, or we are studying to understand the pathophysiology of the disease. Methodology in vitro model, we have used HepG2 cells, and for in vivo studies, we have used C57BL6J mice. We have classified the study into 4 different groups: control, in vitro, that is palmitate, and in vivo, that is high cholesterol, high fat diet, that is having 20% of the fat and 2% of the cholesterol. And another group is ethanol group, in which we have used ethanol on increasing concentration with time, and last group is the combination of high fat and ethanol group. In vitro preliminary screening, we have seen that palmitate ethanol decrease a significant cellular viability in combination at 500 micromolar dose of the both palmitate and ethanol. The same expression of this cytokine release was seen using HepG2 cell supernatant, in which TNF-alpha, IL-1 beta, IL-6 was significantly increased in comparison to control group and other palmitate and ethanol group. The same study was complemented in vitro model HepG2 cells using fluorescence microscopy. We have done different microscopy techniques to determine the reactive oxygen species load, lipid accumulation using Nile red, calcium release for endoplasmic reticulum stress using flow 3am, and mitochondrial membrane potential. And in vivo studies, the results are presented as weight pattern and food intake of the C57 mice. Figure A represent the significant increase in the weight of the fat group as compared to the control group. The same pattern of the body weight was seen using bar graphs, and the liver weight was significantly higher in the fat group as compared to the other 3 groups. Metabolic profile, we have seen significant increase in the glucose cholesterol level, and the ratio of the AST-LT were significantly higher as compared to the control group and fat plus group. That is more than 1, which shows alcoholic liver disease. The same cytokine release and lipid peroxidation using MDA T-bars assay, we have seen a significant increase in the TGF beta and TNF alpha levels, along with the MDA level that was significantly higher in the combined group, that is force 1 group. These are the histopathological slides which shows a fat accumulation in fat FF group, that is second group. The disturbed architecture of the hepatocytes and the fibrotic features were seen in the fat plus ethanol group, and the collagen depositions were also high in the last group. Hepatic protein expression using Western blot technique were studies in which we have seen SREPV1, PPAR gamma, and CD36 expression was increased in the FF group plus ETL ethanol group as compared to the other group. The same expression was seen in the ECM degradation marker TGF beta R2, Procol 1A1, and CYP2E1, which is an inducer of induced due to ethanol treatment. NRF2 SOD1 catalase were significantly decreased due to chronic injury. The same were complemented for apoptosis. We have seen that BACs were significantly increased in the last group. The hepatic gene expression using RT-PCR we have studied, and the result were determined by delta-delta CT method, in which IL-6 and TNF alpha was also significantly increased in the last group as compared to the other three groups. Summary and conclusion: the present study provides a 8-week model of chronic liver damage by administration of alcohol and high cholesterol, high fat diet model system resembling clinical conditions in humans. The result indicated that co-administration of ethanol along with fat group was critical in causing chronic liver injury in terms of inflammation, fibrosis, and collagen deposition. Our results show the significant outcome in terms of weight profile and metabolic parameters, histological finding, protein and gene expression studies with respect to fat plus ethanol group induced chronic liver injury.
Okay, that's a good study, but in the interest of time, probably we don't have time for any questions actually.
Sorry for that. Actually, there isn't.
Yeah, because it's a good study, but
technical error.
Okay, the next topic is by Dr. Govardhan Bale on 17th beta hydroxysteroid dehydrogenase 13 loss of function does not confer protection to NAFLD in the Indian population. The study is from ICS Group SRFR Research Labs, IIT Hyderabad.
A very good evening all. I am Govardhan Bale from Asian Healthcare Foundation, AIG Hospital, Hyderabad. This is a recent study from our lab. We found HSD17 gene loss of function does not confer protection to NAFLD in Indian population. Jiva studies identified a splice variant in HSD gene reported to confer protection against all the stages of liver disease spectrum and also associated with reduced liver levels of, and it also mitigates the liver injury associated with PNPLA3 I148M variant. And this variant also associated with normal liver histology and simple steatosis. More to this, in addition, this gene being explored as putative therapeutic target, taking an advantage of its protective role in NAFLD. With all these, we explore the association of variant with liver enzymes in individuals with NAFLD in Indian ethnicity. In this study, we included a total of 583 individuals. Of these, 424 were NAFLD patients and 159 were controls. The DNA was isolated from blood and tissue. Genotyping was done by SNP sequencing and qRT-PCR. The tissue assessed by immunohistochemistry. The statistical analysis was appropriate. Statistical analysis was used to see the association between the groups. This the table shows the association of anthropometric and clinical parameters between the groups. The left side table shows association comparison between controls and NFLD patients, and the right side table shows NFLD patients with high ALT and normal ALT group, and there was a significant association seen between the groups for anthropometric and clinical parameters. This is electropherogram of variant region of HSD and PNPLA3 variants, which showing wild heterozygous and homozygous genotypes. The genotyping result shows there was no significant difference between NFLD patients and controls for the splice variant. As it is known that the variant associated with liver enzymes, we have seen the association between liver enzymes and splice variant. In left side graph shows the association of liver enzymes in HSD wild and HSD carriers, and there was no significant difference. The right side graph shows association of liver enzymes in PNPLA3 carriers with HSD wild and HSD variant, and there was no significant difference was observed between the groups. And these results show that there was no protective role of the variant against the liver injury in NFLD patients. These images shows HSD protein expression and its subcellular localization in the liver. The panel A shows wild type for the splice variant, panel B shows heterozygous, and the panel C shows mutant type. The H&E stain shows the steatosis in all the panel. The immunohistochemistry shows the HSD protein expression, and the protein expression was cytoplasmic. And if you see the red arrows, the expression is more at lipid droplets. If you see the expression between wild, het, and mutant, the genotype difference in the expression was observed as reported, and there was no association of the expression with steatosis. These results shows there was difference in genotype-based HSD protein expression, but no association with steatosis. In summary, there was no significant difference was noted in the frequency of splice variant between patients and control, and we screen for other variants in HSD gene intron exon boundaries, and no variants were identified. In addition to this, no differences in liver enzymes was seen between PNPLA3 carriers with HSD wild and variants. More to all this, there was no significant difference between the ALT-AST level between HSD wild and variant carriers. With this, our study concludes that there was no association of splice variant in HSD 17B13 gene with protective against NFLD in Indian ethnicity. And absence of this protection in variant carriers is intriguing and need to be explored. Currently, this gene being explored as therapeutic target. Any therapeutic exploiting in the gene may be proceed with caution in the gene genetically distinct ethnicity. On behalf of all the authors, I thank you, the organizers, for giving me this opportunity to present our work here. Thank you all.
Yeah, that's a good study, good observation study. Can I just ask you, what is actually the function of this gene here? And why do you think it's not expressed in the Indian cohort?
The main function of in 2011, there was a study where they explored first time this gene as a retinal dehydrogenase activity in liver. After that, in 2018, there is a article published in NAGM where they shown it is associated with lipid droplet protein, and they seen the protein is expressed more at the lipid droplets, and they are showing that when there is a variant in this gene, they are telling that it will mitigate the steatosis in NFL patients. But when we see in our population, it is expressed and there is a genotype based difference, but we are not seeing any association with the steatosis.
Do they have a different SNP's expression compared to what's seen in the Western population?
For that also, we screen the other variants which are found in this gene, but we are not found any variants in this gene.
Sure. Okay. Thank you. Thank you, Dr. Govardhan.
Thank you.
That concludes this part of the session. That's fine. Thank you, Dr. Govardhan. I think this concludes part of the session. I think Dr. Abha Nagral.
Yes. So good evening all. May I now invite Dr. Sagnik Biswas, Senior Resident Department of Gastroenterology from AIIMS, New Delhi, to make a presentation on pregnancy outcomes in Budd-Chiari syndrome, a tertiary care experience.
Good evening to everybody present. Ma'am, may I start my presentation?
Yes, please.
I will be sharing our experience with pregnancy outcomes in Budd-Chiari syndrome at the All India Institute of Medical Sciences, New Delhi. As we know, Budd-Chiari syndrome results from is a form of hepatic venous outflow tract obstruction resulting from an obstruction in the hepatic vein or IVC or both. And pregnancy is one of the known factors which can cause this. So we were interested in finding out the impact that Budd-Chiari syndrome has on pregnancy outcome, which according to us can be analyzed in three ways. One is the impact of the chronic liver disease or cirrhosis on subsequent pregnancies. The second is the impact of anticoagulation use on fetal development. And the third being the impact of interventions done for Budd-Chiari syndrome on future conceptions and its outcome. At present, there is only a scant amount of literature available on this, mainly in the form of case reports and case studies. In terms of methodology, this was a single-center retrospective analysis of female patients with Budd-Chiari syndrome who had attended our liver clinic from a time period of January 2017 to December 2020. The inclusion criteria included all females with Budd-Chiari syndrome who consented to participate in our study, while we decided to exclude patients with major comorbidities in the form of diabetes, cardiopulmonary and renal disorders, gynecological conditions which would lead to primary infertility like such as PCOS and abdominal tuberculosis, and patients who were suffering from other coexistent etiologies for chronic liver disease. In terms of management protocol, all of the patients were considered for endovascular intervention and anticoagulation, and they were kept on serial follow-up with routine imaging at around 3 to 6 month basis to assess for stent obstruction. And if they were planning a family, they were advised to switch to LMWH. Data was collected in the form of baseline demographics, clinical presentation, obstetric history, and its outcomes. So coming to the results, as this flowchart shows, we had around 152 patients attending our clinics. Based on those who refused to give consent and the incomplete data, 121 patients were found to be eligible for inclusion. In our observation, we mainly found that there were patients could be grouped into three categories. Group 1 was defined as those who had Budd-Chiari syndrome diagnosed prior to any conception. They comprised a major portion of our patients, accounting for almost 47.9%. Group 2 were those in whom the diagnosis was made during or after a pregnancy, but before completion of their family. They comprised around 32.2%. The remaining 19.8%, as shown, were those who were diagnosed after completion of family. The outcomes have been shown here in terms of completion of a slide. We will discuss this in subsequent slides. So coming to the baseline demographics, we can find that as expected, patients who belong to group 1, where the diagnosis was made prior to any conception, were younger in age. Their age of symptom onset was younger, and they were also diagnosed at a younger age as compared to group 2 and 3, where the diagnosis was made before and after completion of family respectively. However, in all three groups, there was no delay in terms of diagnosis, significant delay in terms of diagnosis, or any significant delay in terms of intervention. Comparing the baseline lab parameters, we find that there wasn't much significant difference across all three groups. And in terms of the baseline severity of illness scores, there was also not much of a significant difference, although in group 2 and 3, the MELD score and child score was higher as compared to group 1, although the difference was not found to be significant. So coming to the outcomes of our patients who belong to the first group where diagnosis was made before conception, 21 patients were found to be primarily infertile, out of which 15 patients were considered for pregnancy outcomes because they had undergone an intervention greater than 1 year. Since they were primarily infertile, they did not have any pregnancies before intervention. However, after the intervention was made, we found that 5 patients were able to conceive 11 times. And out of these 11 pregnancies, 4 were successful in terms of 3-term and 1 preterm delivery. 7 patients, however, had abortions prior to 20 weeks of gestation. The predominant mode of delivery was vaginal. In terms of patients who had spontaneous conception despite having a Budd-Chiari syndrome, they comprised 5 patients, and out of these 5 patients, the pregnancy outcomes were good, and they were able to have almost all 4 conceptions post-intervention were carried to term. The important thing that we want to highlight through this slide is the improvement of fertility outcomes in patients who had primary infertility. We find that they had conceived almost 11 times, and 4 out of 11, which is almost 36% of these pregnancies, were successful. And in the pregnancies that were aborted, an interesting finding that we had was that all of these patients did not switch to injectable anticoagulants during the period of organogenesis. By the time the pregnancy was diagnosed, the period of organogenesis was over and they were on oral anticoagulants. The patients who had successful pregnancies, however, had switched to injectable drugs during this first trimester. Now, for coming to group 2, where the diagnosis was made during or after any pregnancy, but before their family was completed, we decided to analyze this in 2 parts. First, we decided to compare outcomes for those who were diagnosed during a pregnancy as compared to those who were diagnosed in the postpartum period. This provided us with an interesting finding in that 5 patients who developed Budd-Chiari syndrome acutely during a pregnancy had successful outcomes in almost 10 pregnancies during the diagnosis. However, in pregnancies following the intervention, they were not able to conceive even once, which means that if a patient has acute Budd-Chiari syndrome during the current conception, her future conceptions she's at a poor risk for having future conceptions. In terms of patients who were diagnosed in the postpartum period, they were 11 in number. Post-intervention, almost 5 pregnancies were found in these patients, and 3 out of 5 pregnancies were successfully carried to term, showing that Budd-Chiari syndrome diagnosed in the postpartum period has a better outcome in terms of future pregnancies than when diagnosed during a pregnancy. In the second analysis that we did for this group, we compared those who had history of recurrent abortions as compared to those who did not have a history of recurrent abortions. However, we found an interesting finding here that in both groups, the number of conceptions post-intervention were low. In the patients who did not have prior conception, only 5 women were able to conceive, whereas in the patients who had a history of prior conception, only 3 were able to conceive. And we have attributed this to the fact that the diagnosis in these patients was made at a later age, and these patients also had a higher MELD score as compared to group 1. A higher MELD score and advanced age are both known risk factors for having lesser number of pregnancies in this group, and therefore can explain our findings. In group number 3, we had patients who had Budd-Chiari syndrome diagnosed after completion of family. They essentially formed the control arm of this group, having almost 66 successful pregnancies out of a total of 72. So summarizing our results, we had a total number of 24 patients with primary infertility. 21 of these underwent intervention, while 14 did not. They comprise 19.8% of our study subject, and current estimates for our country place the primary infertility in Budd-Chiari to be around 20 to 25%. 33.3% of our infertile patients, which account for 5 out of 15, were able to conceive with intervention, out of which 4 conceptions, which is almost 36%, were successful. The predominant mode of childbirth in our patients was normal vaginal in 88% patients, which constitutes an important finding because the patients with varices are considered to be at high risk of developing bleed during the second stage of labor. However,
Dr. Biswas, may I just interrupt you? You're well above 7 minutes. If you can quickly wind up.
Ma'am, I'll just wind up, which comprised around 88%. And with intervention, we had 12 out of 23 successful pregnancies. An important point was that 30% of our infants had a low birth weight, indicating that a good antenatal and perinatal care is required in such cases. So in conclusion, pregnancy is safe in Budd-Chiari syndrome, as is the mode of delivery being normal vaginal, and high rates of low birth weight are found as compared to normal population. The use of anticoagulants are not associated with increased bleeding episodes or teratogenicity. Thank you.
Thank you, Dr. Biswas. That was a very interesting paper. I wish we had some time for discussion. Unfortunately, we don't. So we'll move on to the next one. Dr. Goel, please.
Yeah. So the next presentation is by Thakkar Mala Paresh Bhai from Department of Pediatrics, Postgraduate Institute of Medical Science, Chandigarh. And the title is Prevalence and Characteristic of Liver Involvement in Cystic Fibrosis Patients, an Initial Experience from India. So Dr. Thakkar, you are welcome. Please present your work.
So is my screen visible?
Yes, it is visible. Can you make it to full?
I made, sir. Is it full screen now?
Yeah.
Okay. I'm Dr. Malo Thakkar from Department of Pediatrics, PGI Chandigarh. I'll be presenting the prevalence and characteristics of liver involvement in cystic fibrosis patients and initial experience from India. So CF is an uncommon autosomal recessive disorder that results in dysfunction of an epithelial chloride transporter channel due to CFTR gene mutation on chromosome 7. This results in an abnormally thick secretions and affects organs like lung, pancreas, liver, intestine, and reproductive tract. CFLD, that is cystic fibrosis associated liver disease, affects about 26 to 45% of patients and is considered third most common cause of death in cystic fibrosis after lung disease and transplantation related complications. However, limited data is available on the epidemiology and risk factors leading to CFLD in development of Indian children. The aims of our study was to describe the prevalence and characteristics of patients with CFLD as compared to patients without CFLD. For this, we conducted a prospective observational study from January 2019 to December 2020 in the Department of Pediatrics and Hepatology, PGI Chandigarh. And the inclusion criteria was children less than 18 years of age with a diagnosis of cystic fibrosis. The diagnosis of cystic fibrosis was established based on the presence of typical clinical features on history or a history of a sibling with cystic fibrosis or a positive newborn screening, plus 2 elevated sweat chloride levels, that is defined by a value of more than 60, or identification of 2 CF associated gene mutations or an abnormal nasal potential difference. The definition of CFLD was established by at least 2 of the criteria, that is hepatomegaly and or splenomegaly confirmed by USG, abnormal LFT, that is above the upper normal limit, imaging or fibroscan evidence of liver or biliary involvement, and a liver histology suggestive of chronic liver disease. We included for our diagnosis, 30 patients of the patients presenting to the pediatric pulmonology clinic had cystic fibrosis, out of which 7 of them, that is 23% of our patients, had CFLD. Coming to the clinical variables, 20% of the patients had hepatomegaly and 3% of the patients had splenomegaly. Only 3% of the patients did not have any hepatosplenomegaly with CFLD. 23% of the patients, that is all the patients with CFLD, had transaminitis, and 71% of the patients with CFLD had significant elevation in the LSM values above the cutoff which we took was 5.65 kilopascal. The association of liver stiffness with CFLD, this highlights that the median LSM IQR in patients with CFLD was 6.4 kilopascal as compared to 4.3 kilopascal in patients without CFLD. And the sensitivity and specificity at a cutoff of 5.65 was 83% and specificity was 100%, which was statistically significant. Coming to the clinical presentation, the most common clinical presentation from the liver point of view was asymptomatic. The other common presentations were failure to thrive, oily stools, and recurrent respiratory tract infections. However, all the patients with CFLD had malnutrition defined by height or weight for age less than -2Z score. And also an important finding was that there was 28.5% of patients with CFLD had an impaired HbA1c, that is between 6 to 6.5, and 57.1% of the patients had an abnormal HbA1c above 6.5%. On comparison of variables between CFLD, patients with CFLD and without CFLD, there was not much significant difference in the age, gender, age at diagnosis, or the sweat chloride levels. However, one important significant difference was in the patients with CFLD. 57.1% of the patients had Delta F508 mutation positive. That is not statistically significant, but numerically that is significant. And also, all of the patients had malnutrition, and transaminitis, hepatomegaly, and liver involvement based on LSM fibroscan were statistically significant. Coming to the outcomes, the patients with CFLD had higher mortality rates as compared to those without CFLD, and this was attributed to the higher frequency and severity of infections, leading to respiratory exacerbations among patients with CFLD. This is the first study of India describing the prevalence and pattern of liver involvement in cystic fibrosis. And prevalence of cystic fibrosis in our unit is 3.37%, and among them the prevalence of CFLD was found to be 23.3%. Clinical presentation of CFLD is largely asymptomatic. However, there is an increased risk of malnutrition and infections, so a screening for all patients is necessary. There is a limited data on CFLD in pediatric population. In our study, the cutoff for significant LSM was taken as 5.65, and 71% had significantly elevated LSM with a median value of 6.4. The sensitivity and specificity were 83 and 100% respectively. According to the CF consensus definition, the fibroscan has a sensitivity of 63 and 87% respectively. The following variables were statistically significant for CFLD, that is transaminases, hepatomegaly, and LSM significantly elevated. Patients with CFLD had a higher mortality rate as compared to those without CFLD. And this could be due to the increased number of gram-negative infections in these patients. The limitation of our study was a single center observational study with a limited sample size that was of 30, and it is an exploratory design. However, in future, a multi-centric registry is required for CF patients in India, and non-invasive methods like fibroscan should be explored for early diagnosis and prevention of morbidity and mortality associated with CFLD. In conclusion, CFLD is not uncommon among patients with cystic fibrosis, and the most common presentation is asymptomatic, and early diagnosis can prevent progression of disease. Thank you.
Dr. Malo.
Yes, sir.
This you have given how many participants had deranged LFT, means OTPT were elevated, but what was the value?
Sir, we took a cutoff of 40 for AST and 41 that was done on.
That is acceptable. 40, 41 is fine. That's not a problem. Basically, what was their OTPT value? Median.
Sir, it was around 60 to 70. Not significantly elevated. Yes, sir.
Not much elevated. One and a half time.
Yeah, not much elevated, but it was a consecutive elevation.
Right. And why you have taken this 5.65 kilopascal cutoff?
Sir, actually, we reviewed the literature for where they have defined the significant LSM cutoff, and that was ranging between 5.5 to 5.9. And in our study, we found that 5.65 at a cutoff of 5.65, it was 83% sensitive and 100% specific for cystic fibrosis. So we took a cutoff of 5.65.
I think this 5.65 is from Dr. Koshni's DAS study, which was published in Hepatology, where the mean value was 5.6. And but if you see the 95th percentile, that was going up to 8.5. So you can reconsider to redefine your, because it was not anyway your primary objective, but anyway it was a good effort because it's such a rare data. Nice.
Okay, sir.
Yeah, good study. Just one comment. What was the incidence of biliary involvement in these patients? You have mentioned transaminitis. But we know that in cystic fibrosis, it's more of a biliary picture, a cholestatic.
Yes, cholestatic picture. We had not done a GGT, but ALT was also significantly elevated. So all these 7 patients had a ALT elevation, but as such, clinically, none of them presented with a jaundice or a features of cholestasis.
And serum alkaline phosphatase, you can talk about. What was the value?
Sir, it was it was slightly higher than the median for AST. That was between 80 to 90. But again, it was not very high as in hundreds.
Dr. Sadhna Lal wants to know how was the stiffness done? What is the normative data for children in this age group? Do you have a normative data
In Chandigarh, the normative data has been generated by our department.
Right.
Yes, ma'am.
Have you used that?
Yes, ma'am. We took the help of the Department of Hepatology. That's adult
No, hepatology is an adult department. They don't deal with
Yes.
children.
Yes, ma'am. Yes, ma'am. But the probe used for fibroscan was an age-appropriate probe.
I'm talking about normative data, Mala.
Yeah, ma'am. We had considered less than 5 kilopascal as
No,
normal.
we have data available which is specific for diseases, portal hypertension, controls, etc. from Chandigarh.
As you can see,
Okay, ma'am.
Yeah, point well taken. I think, Mano, you should look at that.
Sure, ma'am.
We don't really have more time. I think it's an important point Dr. Sadhana is making.
Sure.
So I think, thank you for your presentation. I think we'll end the discussion here. Thank you.
Sure.
Thank you.
Thank you. May I invite the next speaker? I am Sunil Dadich. The next speaker is Sandeep Kumar Vishwakarma. His topic is bioengineering humanized neolivers to produce cell-free exosome for supporting liver regeneration in chronic condition. He is from Department of Center of Liver Research and Diagnostics, Deccan College of Medical Sciences, Hyderabad. Dr. Sandeep, if you are there, start sharing your screen.
Yeah, thank you, sir. My screen is visible, sir.
Yes, go ahead.
It's visible, yes.
Yeah, thank you, sir. A very good evening to everyone. This study relates to the development of bioengineered humanized neolivers to produce cell-free exosomes which can be used to support the liver regeneration in chronic condition. So as we all know that the major complications of chronic liver disease cirrhosis as well as liver cancer accounts almost 3.5% of all deaths worldwide, and which is associated with disability and significant decrease in health related quality of life. Although the liver transplantation is the only management option, but has certain limitations for the availability of the cadaveric or living donor organs, and is quite risky and expensive, so it cannot be afforded by the general population in majority. So there has been huge demand in India for specifically in India for the organ transplantation, or we need some other strategy where we can suffice the need of organ transplantation. So exosomes we thought of, and which is extracellular vesicle. It is produced in the endosomal compartment of the most of the eukaryotic cells. Why we selected the exosome? Because it has several important functions. It plays a significant role in the regulation of cell activity through transfer of biologically active molecules like proteins, lipids, DNA, RNA, microRNA, several other things. It has also role in cell-to-cell and cell-to-extracellular matrix communication, which can accelerate the repair and regeneration process. The another advantage is that the most important thing of exosome is that it is inert material. So, and it has higher or longer half-life in vivo after infusion as compared to the cells. The tissue-specific exosomes from healthy cells contain molecules which are quite essential in specific tissue repair and regeneration process. But the major challenge is that it is very difficult to obtain tissue-specific exosomes, and the second is that there is very limited yield of exosomes using the available sources and methods. So considering these points, we engineered a neoliver in our laboratory, which we used as a factory for production of tissue-specific exosomes, which can be used for the wider regenerative applications, specifically in chronic liver disease model. So how we did this? We just first generated the genogenic whole organ scaffold using the decellularization technology, where we used rat liver, whole rat liver. We perfused them with different grades of detergents, and then we removed all the cells, just leaving behind the extracellular matrix of the total liver, and then again infused the human hepatic progenitor cells in that, matured them into the hepatocytes into a bioreactor module, and then culture supernatant we started collecting from that, and from the culture supernatant we extracted the exosomes and then cultured with the human hepatocytes, and tried to observe either hepatocytes, injured hepatocytes take these exosomes or not. And after confirming that, we went to the CCL4 induced chronic liver injury model into skid mice, and then we infused these exosomes through tail vein and tried to see where these exosomes are going and how they are acting, either they are able to recover the function and structures or not in CCL4 induced mice. So this is typically a neoliver bioengineering technology which we do in our laboratory. This is very simple. We just take the whole organ, remove all the cellular components from there, just leaving behind the architecture of the organ, and again infuse the human hepatic progenitor cells so that they can be grown inside this 3D liver architecture, and we can produce the new liver. That's what we have done. When we were infusing the cells in these liver, so we were quite worried, like where these cells are going, either they're making any occlusion or not. So we labeled these cells with DID and then infused into the liver through hepatic artery, as well as portal vein also in different experiments. So we saw that these DID labeled cells are uniformly distributed throughout the liver parenchyma spaces. And after 7 days of culturing, they had almost 97% of engraftment efficiency. They were almost expressed equal level of transcription factors which are present into the human liver tissues. So once we established this model, then we collected the culture superintendents from the bioreactor module and then did a scan electron microscopy to identify either the exosomes are there or not. So we could found that there are uniform size of 30 to 100 nanometer size of exosomes culture supernatant, and they were expressing CD9, which is a specific marker for the exosomes. And more importantly, the bar graph which is showing here, these bioengineered humanized neolivers produce 100-fold higher number of exosomes as compared to the 2D culture system. That's what our major purpose was, to produce large number of exosomes. And these exosomes expressed sphingosine kinase and other markers. And when we cultured them with cells, so the cells had taken up these exosomes that we could visualize by the DID labeling of these exosomes under the confocal microscopy. So the next experiment after in vitro, we did in vivo
already
experiment.
6 minutes, Dr. Sandeep,
Yeah.
just to be aware. So it's already 6 minutes. You have only 1 minute left.
Yeah. So next we did the animal experimentation of CCL4 induced mice, where we infused through tail vein, and we could visualize with DID that these exosomes are going into the liver of skid mice, where they could improve the liver histology, some level of liver function parameters, and we could provide the evidence that this was because of the exosomes infusion, and there was reduced oxidative stress and increased level of SOD, and transcription factors were also showed some improvement in chronic liver injury model. So we could say with this experiment that this particular model system, what we established by engineered humanized new liver, it can be used as a factory for producing large number of exosomes. And these exosomes we can easily track and track both in vitro as well as in vivo using the DID labeling. And they also support the liver architecture as well as the functional response during the chronic liver injury model. Thank you, sir.
Thank you, Sandeep. Nice experimental study. But tell me one thing, how did you give them the tissue specificity? Why did they only go to the liver and do this function?
We wanted to say, like, we wanted to use these exosomes for a chronic liver injury model. So we infused the human hepatic progenitor cells that were EpCAM positive cells. So that's how we can say that, like, these were liver specific cells and liver specific exosomes.
Yeah, Dr. Sandeep, very nice study. I have a question. What are the problems with using exosomes for engrafting into the liver?
Biggest problem is that the delivery is a challenge, because most of the exosomes directly go into the lungs. So that is a major challenge. But in case of liver injury, we could see that more than 60 to 70% of exosomes directly goes into the damaged liver side.
So any side effects or problems with this use of exosomes?
we couldn't see in our preclinical experiment, we couldn't see anything, sir, because these are these are cell-free products. So I don't see any ethical challenge also in that. And the second thing is that they can cross the any endothelial barrier, so they can be easily delivered. Only thing is challenge is that we can produce in large number, and the source of cell is a major challenge.
Okay.
Yes.
Thank you very much. It's a very nice study.
Thank you, sir. Thank you so much.
So we move on to the second paper, and this will be presented by Dr. Arun Walson from PGI Chandigarh, and he's going to talk about pragmatic study comparing efficacy of early empirical versus preemptive ACLF patients with suspected IFI. So I think it's empirical antifungals.
Sir, is my screen visible?
Yeah, it's visible.
So greetings from the Department of Hepatology, Chandigarh. I thank the organizers committee of the INASL for helping us showcase our research on two strategies of antifungal therapy in acute and chronic liver failure patients with suspected IFI. So IFIs are reported in around 5% of cirrhotics and around 15 to 40% of patients with ACLF. And IFIs lead to higher organ failures, treatment failures, increased morbidity, healthcare costs, is a reason for delisting from transplant, and also high mortality. And early diagnosis and treatment of invasive fungal infection is an unmet goal currently. And the IDSA recommends treatments based on clinical suspicion or surrogate markers of mycological evidence. Currently, there is lack of data on the most effective type of antifungal strategy in cirrhosis and ACLF patients. So this is showing what are the options that are available. So we have a four-pronged approach towards antifungal therapy in patients. So if it is based only on risk factors, it is called as prophylactic treatment. If it is based on risk factor and clinical features, it is called as empirical treatment. If it is based on risk factors, clinical features, and mycological evidence, it is called as preemptive treatment. And if you have culture or invasive tissue sample positivity, it is called as definitive treatment. So our research question was, does an early empiric antifungal therapy improve 28-day overall survival as compared to a preemptive strategy in critically ill non-neutropenic adult ACLF patient with suspected IFI, for which we included all critically ill non-neutropenic patients with suspected IFIs, and our intervention group was the empiric strategy group, and the comparative was the preemptive strategy, and our primary outcome was 28 days overall survival. So our sample size came up to 99 in each group. However, due to the ongoing COVID-19 pandemic, we had to report our pilot data. So the primary objective was to assess the impact of the early empiric versus preemptive systemic antifungal therapy in ACLF patient with suspected IFI on 28-day overall survival. And we had multiple secondary objectives, including developmental of new onset IFI, any in-hospital mortality, IFI attributable mortality, the evolution of ACLF based on organ failures, mechanical ventilation, length of ICU stay, etc., and also the adverse events. So it was a pragmatic, single-centered, prospective, parallel group, randomized, open-labeled, blinded endpoint study. All critically ill adult patients were included by both the APASL or the EASL definition, and the patient should satisfy all three. That is significant hospital contact, risk factors from the host of risk factors which are already been proven in multiple studies previously, and clinical risk factors including unresolved sepsis despite broad spectrum antibiotics of beyond 3 days. And we defined appropriate antibiotic as a penum or a colistin if there is nosocomial pneumonia, and a gram-positive cover for at least 3 days as per our liver ICU policy. And there is recrudescence of fever, any tracheobronchial sinonasal infection. And also we found that unexplained HE after a clinical improvement without any obvious precipitant signs were also a risk factor for IFI. These were the exclusion criteria, all standard exclusion criteria, including cancers, previous reactions, and moribund patients, especially in ACLF, more than 4 organ failures or brainstem signs of brainstem death, or an expected ICU stay of less than 48 hours. So this is our consort. We had finally randomized around 61 patients and excluded 90 patients who met the exclusion criteria. There were 30 in the empiric group and 31 in the preemptive group. All the patients, none of them were lost to follow-up, and all were included in the final intention to treat analysis. So all the patients received standard medical therapy, including nutrition, albumin, blood component support, broad spectrum antibiotic as per our protocol. So baseline characteristics are patients largely included adult males of around 40 to 44 years of age. The acute and chronic predisposition precipitants were largely alcohol in around 80% of the patients. There was no significant difference in the randomization from admission. However, as expected, the day of starting antifungal from randomization was significantly different because of the strategy difference. And the MELD and CLIF SOFA were, the MELD score was significantly worse in the empiric group. At baseline, there was no significant difference in the number of proven, probable, or possible invasive fungal infections in either groups. The bacterial infections at admission, randomization, and during the study period were non-significant between the group. Other baseline characters were also non-significant. I'm skipping that for the lack of time. So this is our primary outcome. So in the empiric group, there was significantly improved survival of 46.7% as compared to 13% in the preemptive group, with an adjusted hazard ratio of mortality of around 0.37. And then we adjusted for the baseline randomization CLIF-C-OF score and the days to randomization. And we got a number needed to treat of 2.96. The other secondary objectives, there was no significant difference in the new onset IFI or in the disease severity score as CTP or treatment success rate, adverse events or serious adverse events. However, IFI attributable mortality, in-hospital mortality, and the improvement in disease severity were all favoring the empiric group. In conclusion, we found that antifungal initiation in ACLF patients based on risk factor and clinical suspicion, that is the empiric strategy, improved their survival rather than waiting for a radiological and mycological evidence of IFI as per the preemptive strategy. So what were the strengths and limitations of our study? This is the first study to assess the efficacy and safety of two strategies of systemic antifungal therapy in ACLF patients with suspected IFI. This study addresses a specific subgroup of sick patients who have dismal prognosis without transplantation. Our study had high intervention adherence and no patients were lost to follow-up. And the risk of bias of an open label was minimized by the probe design. And our primary outcome was robust and less likely to be influenced by observer bias. The limitations, however, that our study being a single center study and was being conducted at a tertiary referral center, so the empiric therapy may have got delayed due to admissions in other hospitals. Due to the ongoing COVID-19 pandemic, the recruitment became difficult and we were forced to report the pilot data. Our recruitment rates for patients were lesser than expected due to high mortality of in the high grades of ACLF. As you can see, around 90 patients were excluded because of moribund state. Thank you.
Thank you, Dr. Arun. It's a very interesting study. I have two questions for you. The first one is, why did you choose liposomal amphotericin B in your patients? And the second question is, how many had proven fungal infection in your study at the end of the study, maybe?
Okay, sir. So the first question, sir, we used antifungals, not just liposomal. We had used as per the clinical suspicion. If the clinical suspicion was more towards the invasive aspergillosis, we had used liposomal amphotericin B. If candidemia, invasive candidemia was the suspicion, we have used one of the echinocandins. Regarding your second question, sir, we had divided the patients based on proven, probable, and possible infection. At the baseline, there were 3 proven infections in the preemptive group, and there were around 86% and 83% patients were in the probable group, and in the during the study period. So most of these patients whom initially were in the possible group had also converted into probable group. And of the total number of patients, sir, we had 3 proven cases in the preemptive group. And this was expected, as we did not wait for the definite confirmation. And ours being a strategy trial, the exhibition of the antifungals would have negated the culture positivity.
Yes, can I ask you 2 questions? Tarun, that means you used different antifungal compounds for different these 2 groups as per the patient's requirement. So the drugs used were different in both the groups. Number 2, yes.
So we had calculated for any significant difference in the drug group that I did not show in the graph, but overall the antifungal type of antifungal were non-significant between the 2 groups.
Okay. And second is in ICU, as you know, each moment or each hours or each day matters. In the second group, you use the antifungal compound around 3-4 days later compared to the one group. So do you think these groups are comparable? Like in one, you are using drug immediately, in another, you are delaying it and then using it. So in ICU setting, a delay of a few days and then starting a intervention, then comparing both.
Sir, actually, currently, sir, we don't have any data to start antifungal upfront, or nor there is any data in ACLR specific patients or in other high-risk groups like hemato-oncology neutropenic patients. There also, sir, the IDSA recommends that we take an individual approach to the patient, and they do not recommend any one over the other. So both are even Stevens as on date. So we also wanted to see whether our ACLF patients with suspected IFI being as sick or even more sick than neutropenic hemato-onco patients, whether this strategy difference would affect the mortality or survival. So as on date, sir, there is no strong evidence to suggest one over the other. And there was no ethical problem because the all infectious societies recommend an early approach, but they do not, kind of say which is better or which is not. So we really don't know which approach is better.
Yes. And what was the randomization process used?
Sir, we had sealed envelopes, which was done by a third party in the third person, which was computerized, generated. And once the patient fitted the randomization, the sealed envelopes were opened and the patient was assigned. And we said, sir, it was a open label, so we knew the intervention arm, but the analysis was done. At the end was blinded, sir. It was done by a separate one of my co-guide with other person who were blinded to the intervention, sir, and the outcome.
Thank you. Thank you. Very nice.
Thank you, sir.
Thank you.
So I will invite now Dr. Rakhi Maiwal and Dr. Anand Kulkarni to judge the next poster session, which is to be presented by Dr. Khwaja Siddiqui and Dr. Sharmeen Ishtiaq.
Thank you, Amrish. So the first presenter would be Dr. Khwaja Aminuddin. He's a DNB resident from Bombay Hospital and Medical Research Hospital. And his topic of presentation is sarcopenia and cirrhosis of liver assessed by hand grip dynamometry. And its association with clinical profile. Dr. Khwaja Aminuddin.
Very good evening, judges. My name is Dr. Khwaja Aminuddin Siddiqui from Bombay Hospital. My topic for today's poster presentation is sarcopenia and cirrhosis of liver assessed by hand grip dynamometry and its association with clinical profile. Hello.
Please continue.
Yeah. Sarcopenia is defined as decrease in muscle mass, strength, and physical activity. It has been published in the previous literature that in cirrhotic populations, sarcopenia is associated with poorer outcomes, increased rates of infection, poor post-transplant outcomes, increased morbidity. Sarcopenia is one of those complications of cirrhosis which does not even revert after liver transplant. In their paper, Hanai and et al. Have reported that sarcopenia, when measured by hand grip strength rather than skeletal muscle mass and fat mass, it was significantly linked to an increased risk of mortality in cirrhotic patients. The aim and objective of our study was to assess sarcopenia and cirrhotic using hand grip dynamometry and correlating it with the clinical profile of cirrhotic patients, and to compare the utility of hand grip dynamometry with psoas muscle thickness by height, which is called a psoas muscle index, as measured by CT scan, in diagnosing sarcopenia and cirrhotics. This was a single center study in which 50 liver cirrhosis patients were enrolled. Hand grip strength was tested by using Cambridge hand grip dynamometer, and the cutoff was taken as 26 kg for men and 18 kg for women. In patients where CT scan was available, psoas muscle thickness was measured at the level of umbilicus, and it was divided by height of the patient. Cutoff was taken as 16.9 mm per meter, as suggested by Gu and et al. Talking about results, 76% patient had sarcopenia in our study as measured by hand grip dynamometry. And the most common cause of sarcopenic cirrhotic was alcoholic liver disease, which was seen in 42.1% patients. When the association with complications was studied, a statistically significant association was noted between bleeding esophageal varices and hepatic encephalopathy and sarcopenia. When the comparison was made between psoas muscle index as measured by CT scan and hand grip dynamometry picked up more sarcopenics as compared to psoas muscle thickness by height, 80.07% versus 23.07% patients. When the correlation of sarcopenia was done with MELD, the higher number of MELD, the higher the MELD score, higher was the number of sarcopenic cirrhotics. It was 86.84% with MELD score more than 14. Similarly, with CTP score in child C, the number of cirrhotic sarcopenic was more. It was 42.1%. Talking about comparison of complication with child B, variceal bleed was common in 21.05% patient and ascites in 63.15% patient. In child score C, hepatic encephalopathy was exclusively seen in sarcopenic cirrhotics. Variceal bleed was seen in 56.25% of patients. In a 3-month follow-up analysis of our data, we found that the patients who had sarcopenia to begin with, all of the complications were more common in them. Hepatic encephalopathy, esophageal varices, and hepatorenal syndrome were exclusively seen in the sarcopenic cirrhotics. Ascites and hepatocellular carcinoma was also more common in the sarcopenic cirrhotics. In fact, a recently published paper in a Chinese population, lenvatinib was given to unresectable hepatocellular carcinoma patients. It performed poorer in patients who were sarcopenia as compared to non-sarcopenic patients. So this was an interim analysis of an ongoing study at a tertiary care center. In our study, the prevalence of sarcopenia was 76%, which is comparable to the previously observed rates of 30 to 70%. Presence of sarcopenia is associated with increased number of complications like esophageal variceal bleeding, hepatic encephalopathy, hepatorenal syndrome, and spontaneous bacterial peritonitis. Lower MELD NA score have a lesser proportion of sarcopenia, and higher score have an increased number of sarcopenic cirrhotics. And when we compared psoas muscle thickness index by CT scan, hand grip dynamometry fares well in picking up more sarcopenics. So to conclude, sarcopenia should be routinely measured in all cirrhotics as it is associated with increased rate of complication. Combining sarcopenia with CTP score and MELD score will help prognosticating patients better. This was tried by Sinclair et al. In their study, which was published in AASLD Hepatology in 2019. Hand grip dynamometry provides an excellent bedside, inexpensive tool to assess patients' functional muscle reserve in cirrhosis. Thank you.
Thank you, Dr. Khwaja. I had few questions to start with. The first thing is, as I expect, this is a prospective study.
Yes, ma'am.
So you did not show us the sample size calculation. How did you calculate a sample size of 50? This is my first question. Second question is, when you have done a follow-up of 3 months, how could you say that this is independent? Why is it not that sarcopenia happens because of a complicated cirrhosis? And how do you say that we should be checking it? How do you conclude that? That is my second question.
Ma'am, samples actually the 50 is that figure which these patients have completed their 3-month follow-up. We have not included all those patients who have not completed their 3-month follow-up, and the sample size we have calculated with the help of an online software in which the confidence interval, the error was taken as 15, and the population size was left blank because our hospital has the population which covers all of the city So the sample size came out to be 45. Regarding the second question, ma'am.
The size came out to be 45. That calculation should have been shown because I don't expect so. And the second thing is, like, if you're saying that your patients had lost to follow up, that data should be shown. Okay, then we will expect that if that is not shown, that everybody has a follow up of 3 months. And then my third thing, like, because you're concluding that everybody should have an assessment, which is very right. We know that sarcopenia is very important. But from your data, how do you conclude that?
Ma'am, in our data, we have seen that the patients who were the sarcopenic at the beginning of the study, at the end of the 3-month follow-up, they tend to have more complications. Plus, in diagnosing sarcopenia, hand grip dynamometry, which is a very less expensive a bedside tool, it can be used more easily as compared to the CT scan or skeletal muscle index thickness, ma'am. There has been studies in India which have proven the benefit of a hand grip dynamometry. A study was done in Gangaram Hospital, which has shown that hand grip dynamometry is a good bedside tool in assessing sarcopenia.
Okay.
One question, Dr. Khwaja, they actually showed that most of the alcoholics had sarcopenia. What was the etiology of patients who developed HCC within 3 months? Was it alcohol or some viral disease?
Sir, 2 patients were hepatitis B related. One was NASH related, and one had alcoholic liver disease, sir.
Okay. Good presentation. So moving on to the next presentation. The next presentation is by Dr. Sharmeen Ishtiaq. He is a senior research fellow from Toxicology and Experimental Medicine Division, CSIR, Lucknow. Over to Dr. Sharmeen.
Good evening to all. My screen is visible, sir?
Yes.
Good evening to all. I'm Sharmeen Ishtiaq. Today, my topic is cytochrome P450 associated dysregulation in the NER process in hepatocellular carcinoma. As we all know that SCC is the 6th most common cancer in the world, and it is associated with the multiple risk factors such as hepatitis B and C virus infection, chronic alcohol consumption, and it has been reported that it frequently arises in context to the DNA damage and chromosomal aberration. Cytochrome P45021 is a P450 enzyme family, and it gets highly expressed in the liver where it works in the metabolism of many xenobiotics and pro-carcinogen. This figure demonstrates the involvement. Sorry.
Yes, sir.
This figure demonstrates the aberration in the DNA damage response pathway, which leads to the development of the SCC. Coming to the methodology, I have developed the SCC model in HD-RED using chemical, and I have analyzed the gross liver morphology, histopathological analysis, and I did the Western blot as well as ISC of the CYP2E1 proteins as well as P53 and MDM2. This shows the development of SCC model in the rat. I have used DEN, that is diethyl nitrosamine, which is a potent carcinogen, and I have administered with IP at the dose rate of 30 mg per kg twice a week. This slides show the gross liver morphology as well as histopathological changes in the liver. We can see there is the appearance of multiple nodules on the liver on the liver surface, and this histopathological changes shows the hyperactivation of the bile duct. We can see the swelling of the hepatocytes and multiple nodules appearance we can see here, as well as in the control liver the normal histoarchitecture is well maintained. We can see the normal hepatocytes radially radiate the normal control. It is near to the control. This diagram shows the regulation of CYP2E1 by P53. Here we can see when P53 bind to the promoter region of the cytochrome P450 gene, it get expressed and it is mainly localized in the endoplasmic reticulum. If there is increase in production of the ROS, there is the induction of unfolded protein response, which get rise, which get due to which there is the endoplasmic reticulum stress, and it may lead to the progression of the SCC. Then we did ISC as well as Western blotting of the CYP2E1. In the ISC section, in the control liver, we can show the expression is only restricted around the central vein, while in the SCC liver, it get diffusely expressed in the tumor tissue. And from the Western blot study, we can see the expression of CYP2E1 is getting rise in the DEN liver. We can also see that the P53 expression is also getting rise in the liver tissue. This suggests that P53 may be involved in the regulation of cytochrome P450 to even enzyme expression. And the conclusion is that the CYP2E1 in the immunohistochemical study, we saw that the expression of CYP2E1 was diffusely expressed in the tumor tissue, while in the control liver tissue, the expression was mainly around the central vein. So immunoblotting study, we find the higher expression of CYP2E1, which we can correlate with the increased incidence of SCC. The increased expression of P53 conclude that P53 might be involved in the regulation of cytochrome P450 as there is the limited data available on the how CYP2E1 is getting regulated by P53. Our study might provide a novel therapeutic intervention in the treatment of the SCC. Thank you.
Good presentation, Dr. Sharmi. Why you chose the DEN as a carcinogen?
Sir, actually, DEN is the potent carcinogen and the incidence of SCC is 100% from the DEN. That's why we have chosen DEN for inducing SCC.
There is no other malignancy noted in this mice other than HCC with high dose of DEN?
So there are other chemicals like CCl4. People have used CCl4 in inducing SCC, reported in paper. But the incidence of SCC was not 100%. That's why we choose 10 for full development of SCC.
Okay, and I would just like to say, how do you see your study going into the clinics?
Ma'am, actually, currently I am further working on this study. I am going at the molecular level, like how CYP2E1, if we are finding the increased expression of CYP2E1 in the SCC, say liver tissue, it may be concluded that it may be involved in the incidence of SCC. So we are working further on the regulation to check the regulation of SCC, so we can further we can work on human sample and for clinical study further.
Thank you.
Thank you, ma'am.
Dr. Amrish, you need to unmute yourself.
So, to preside over the final session of poster sessions, I will invite Dr. Ajay Duseja and Dr. Gaurav Pandey, and both the posters will be presented by Dr. Sanchit Sharma.
Hi, Dr. Gaurav. So, Sanchit, are you there, Dr. Sanchit?
Good evening, sir. I'm there, sir.
Okay. So, I think you can go ahead with your, maybe you are making both the presentations, right?
Can the admin allow me to switch on my video?
Yeah, they should. So, please allow him to share his screen and the video and the audio access.
Yes, sir. I have already allowed.
Allowed, okay. So, Sanchit, you can share your screen and make the presentation. So, Sanchit, Dr. Sanchit Sharma is post-DM fellow at All India Institute of Medical Sciences, New Delhi, and he would be presenting these two studies one by one. So you can go ahead with the first presentation. So the time allotted to you is 5 minutes, and we will have 2 minutes discussion after each presentation. Go ahead, please. We can't hear you, Sanchit. Can you?
So just a second. Okay, good evening, everyone. The topic of my presentation is liver stiffness measurement during the episode of acute variceal bleeding accurately predicts the risk of future clinical decompensation in patients with childhood cirrhosis. It's a proof of concept study. Well, if we know that liver stiffness, it's an important non-invasive tool to predict the clinical decompensation in patients with advanced compensated cirrhosis. In fact, the predictions of the hard liver have been shown to match the gold standard of predicting decompensations, that is measurement of hepatic venous pressure gradient. However, whether this non-invasive tool is relevant on decompensated cirrhosis, probably not. We have good scores like severity of scores like child book scores and MELD score, which are probably more relevant, and hence the stiffness is basic. Liver LSM is an important tool primarily of patients who do not have clinical decompensations. But what about patients who have childhood cirrhosis? That is, they don't have any non-bleed related decompensations, but with a past history of decompensations. Do the stiffness predict the same estimates in these patients? Well, a retrospective study done at our center showed that an LSM measured during the episode of variceal bleeding in a post-hoc analysis of a randomized controlled trial showed that patients who have a post-bleed LSM have a comparable performance to predict the rebleeding risk as compared to the HVPG measured during the variceal bleeding episode. And this was essentially a stable estimate with the performance of the both parameters remaining stable over the 5 years of follow-up. So as we know, it is very rare for a child A to die via bleed. The mortality in these patients is usually less than 5%, contrast 15 to 20% in patients with advanced decompensated cirrhosis. But what about the risk of new onset clinical decompensation? Well, presently, barring the assessment of the MELD score, which is usually the similar in these patients, and portal pressure estimation, that is the HVPG of 16, we really do not have tools to assess the risk of clinical decompensations in these patients. Hence, we hypothesize that whether the liver stiffness measurement during the episode of acute variceal bleed could potentially be used to predict the future events accurately in these patients. So this was a prospective observational study with a pilot design. We measured the liver stiffness on day 2 and day 3, primarily by the logistics that the patient presents to the room after resuscitation after day 1 in patients with an index child A patients with index event as an acute variceal bleeding with no previous decompensations. The probe used was EcoSyn 502 and the probes were used as per the manufacturer's recommendations. We also assessed HVPG in these patients and MELD score. The outcome event was taken as the new onset clinical decompensation, that is the ascites, hepatic encephalopathy, or a repeat episode of bleeding at 6 months for the present study. The primary outcome of this study was to assess the performance of this post-bleed LSM and compare this with the established indicators like the MELD score and the HVPG, to whether it accurately stratifies the clinical decompensations and to calculate the cumulative decompensation by the risk stratification. To see the performance, to see the effect of acute variceal bleeding in patients with higher LSM, we compared these rates of clinical decompensation in this AVB cohort with a cohort of an advanced compensated cirrhosis matched for the stiffness, predominantly using the propensity score matching. So we studied the bidirectional relationship of LSM with acute variceal bleeding and vice versa. So in our study, 109 patients of childhood cirrhosis presenting with AVB as an index bleeding were prospectively recruited. Most of them were of non-viral cirrhosis and were started on carvedilol for secondary prophylaxis. Over a median follow-up of 6 months, almost 1/3 of them developed clinical decompensations, most frequently being ascites, or more than 80% of the patients. Now, what we found when we compared the performance of the post-bleed LSM was superior to both MELD score as well as the HVPG in predicting the all-cause decompensation in these patients. Due to the infrequent events of mortality in these patients, we did not calculate the mortality. We found that an LSM of 47 kilopascals after the onset of acute variceal bleed could accurately stratify the cohort with respect to prediction of clinical decompensation in the next 6 months. Our next objective was to study whether this variceal bleed acts as a catalyst and accelerates the clinical decompensation in these patients with high liver stiffness. So what we compared with the propensity score match cohort, we found the baseline LSM between the AVB LSM cohort as well as the advanced compensated cirrhosis were comparable, but AVB accelerated the rate of development of clinical decompensation, or that is they developed within.
Sanchit, your 5 minutes are over. Need to summarize.
I'm just covering it, sir. So what we found that post-beat LSM could predict the new onset CD clinical decompensations better than MELD score and HVPG, and using the propensity score matching allowed us to identify potentially AVB as a catalyst to trigger the event of decompensation in patients with advanced cirrhosis. Prospective design and a proof of concept were the strengths of the study. Single center study, lack of validation cohort, and a short-term follow-up were the major limitations. So what we can conclude is it is essentially a proof of concept that this can be potentially used to triage these patients with regard to future decompensations, which in the absence of HVPG is presently limited. We require more follow-up, a larger sample size, and a validation in different cohorts to be sure in this regard. Thank you.
Thank you, Dr. Sanchit. You can stop sharing your screen.
Yes, sir.
Okay. I think nice work, Dr. Sanchit. Just one or two quick questions. First is, you said in the introduction, and we know that, the LSM correlates very well with the HVPG, right? And there are lots of studies available, where people have shown that as your, LSM goes up, it correlates very well with the HVPG. So what is the reason that in this particular study, you have found LSM to be even better than HVPG in predicting, the clinical decompensation, say for next one? What is the reason? Why do you think that this is better than even HVPG?
There are multiple reasons. After the onset of clinical significant portal hypertension, the perfect correlation between the LSM and HVPG actually dissociates, and the correlation coefficient is not too great, as shown in pivotal studies, as well as the work done in our study also. The correlation is not that great because the systemic hemodynamics come into play. But at the same time, we don't know what is happening. LSM can be affected by fibrosis, by congestion, even by bacterial translocations, it has been shown. So what is actually happening in the patients with acute variceal bleeding with so much of endotoxemia, so much of translocations, and how is it affecting the liver stiffness that cannot be deduced from the clinical aspects of these studies? Similarly, what people have found that there is a phase of hepatic congestion during the episode of till 10 days of acute variceal bleeding, and congestion may well be picked by the acoustic waves which we use in the LSM. So so it could potentially be a tool as an alternative to.
So I think we got it. So what you're saying is that this may not actually be reflecting only the fibrosis. So there could be some other factors which could have falsely elevated the LSM, I would say, not an exact marker of fibrosis. Fine enough. The second is, these were all consecutive patients of cirrhosis?
Unfortunately, they were not consecutive patients. The patients presenting with the shock and active bleeding, the prime vein was stabilization, resuscitation. So almost 20% of the patients were excluded, but this was the prospective study in that regard.
Lastly, I'm pretty sure you did the LSM on day 2 or 3. So by that time, they were hemodynamically stable. So you have used the main machine, not the portable FibroScan machine, right?
So we were using the EcoSyn 502.
502, okay, fine. And there were no failures with the FibroScan during these?
I was personally doing it. We were using the as per the manufacturer's recommendation, the M-probe in patients with obesity. We were using.
Were there any failures or no?
There were couple of failures, but largely we could get the IQR by M in a desired range.
Okay, Dr. Gaurav, you can go ahead.
The impact of comorbidities, Dr. Sanchit, diabetes, uncontrolled diabetes, or the blood pressure in this?
We did not specifically analyze this, but these were all the patients were of non-viral cirrhosis and on carvedilol.
Right. Any change in delta change of LSM at day 10 or second week? When the
unfortunately, as pointed out in limitations, we didn't do the prospective evaluation after the episode. That is something we will like to do with.
Were all the patients on same therapy, octreotide or terlipressin, or
the vasoactives were primarily terlipressin. However, in the presence of some contraindications like elderly or coronary artery disease, we were giving somatostatin.
Great. Shall we go to the next presentation, sir?
Yeah, we can go to the next presentation. Yeah. Okay.
So my next presentation is long-term outcomes of patients with child age cirrhosis who present with acute variceal bleeding. It's a 7-year follow-up study. So when we see the natural history of cirrhosis, we see there are the stages of cirrhosis defined according to the presence of clinically significant portal hypertension, onset of variceal bleeding, non-bleed related decompensation. I would like you to focus on this stage, that is the stage 3 according to the D'Amico staging of the cirrhosis. In the pivotal study of 475 patients, these patients were 75 in the stage 3, that is patients presenting with variceal bleeding alone. Over 20 years, almost 20% patients died and only 30% developed ascites. So essentially the prognosis in this stage is better than as compared to the patients presenting with ascites or with multiple decompensations. But here is the catch. These patients were of viral cirrhosis. They were from the era of interferon, and there were only 75 patients. Now, as the epidemiology is changing, we need to have more data in patients who are effectively treated with DAAs and non-viral cirrhosis. So AVB is the second most common decompensation event in patients with advanced cirrhosis after ascites. While long-term outcomes in non-viral cirrhosis and effectively treated viral cirrhosis is presently limited, especially from our part of the world. So this study evaluated the relevant outcomes in a large cohort of a childhood cirrhosis from a single center study. This was a retrospective analysis of a prospectively maintained database with a reliable follow-up of both non-viral and viral etiologies. The relevant outcomes evaluated were the transplant-free survival, new onset clinical decompensations like ascites, HE, variceal bleeding, onset of hepatocellular carcinoma, and development of ACLF or AD using competing risk analysis. We use the factors, we identified the factors predicting the survival, and a subgroup analysis was restricted to non-viral etiologies since it is this subgroup we wish to study in totality. So overall, we had 492 patients with a reliable follow-up after the onset of variceal bleeding as an index event who were recruited in the study. Almost 80% of these patients were of non-viral cirrhosis, and over the median follow-up of nearly 3.5 years, the transplant-free survival in the overall cohort was 82%, with the new onset clinical decompensation most frequently being ascites as 63%, HCC developed in 7.6%, ACLF by EASL definition or AD developed in 11% of the patients. Now, when we see the cumulative incidence using the competing risk of analysis, the transplant-free survival between the viral cirrhosis as well as the non-viral cirrhosis were nearly similar. Point to be noted is the 7-year transplant-free survival was more than 75% in both the cohorts. A catch point here is almost 90% of these patients had stopped consuming, they did not have active consumption of alcohol. In comparing the new onset clinical decompensation, the cumulative onset CD rates, the decompensation rates were more than 50% at 5 years and 70%, but using the competing risk analysis, we could not find any difference in the rate of onset between the viral cirrhosis as well as the non-viral cirrhosis. On using the multivariate analysis in patients with non-viral etiology, patients with an active alcohol consumption and those with an elevated leukocyte count at presentation could predict poor survival. When we saw the 5-year transplant-free survival, the patients who had an active alcohol consumption, 80% of these patients didn't make it, and almost 90% of these patients had new onset clinical decompensation. So the strengths of the study was it's a large cohort of child cirrhosis of both viral and effectively treated viral and non-viral etiology, and a long duration of follow-up. And we use, as it is imperative in these type of studies, use of competing risk. However, single center study, retrospective design with inclusion of those only with a reliable follow-up of at least a year, and consequently non-consecutive recruitment were the limitations of this study. To summarize, patients with non-viral and viral cirrhosis have comparable decompensation rates and long-term transplant-free survival, with survival reaching up to 80% till 7 years. Among those with non-viral etiology, those with active alcohol consumption, almost 80% of them don't make it after the 5 years. Thank you.
Yeah, thank you, Dr. Sanchit. Again, you can stop sharing your slides. Okay. Nice presentation again. I think just one or two quick questions and then Dr. Gaurav can ask you. The first is you were looking for, some other, clinical outcomes also, including the occurrence of HCC, you said. So my first question is, what was the difference in the occurrence of HCC between the viral and the non-viral etiologies?
Sir, absolutely no difference. We used the competing risk analysis and the GRACE test was again within the non-significant range.
Okay, what do you think? Are your results in line or in agreement with the existent literature, or are your results different from what the existent literature says?
As far as we could, as to the best of our knowledge, the existing literature is regarding the 25-year study from the D. Amico et al. Only, and this was of the different era of different etiology, and in the ours were of the non-viral etiology as well as those of the effectively treated viral cirrhosis. So what we could find is it goes with the study that you stop alcohol, the patient outcomes are as good as those of the viral cirrhosis. It basically outlines the need of it is the etiology treatment which makes the difference even in the after the onset of decompensated cirrhosis, and the dismal survival which is being associated with decompensation probably does not exist who present with this varicose bleeding alone with the no non-bleeding.
For a minute, if you just forget the varicose bleed and they remain compensated after the varicose bleed, which means they tolerated the bleeds very well.
Yes,
so what is the existent literature on child age cirrhosis of viral and non-viral etiologies if they have not bled?
If they have not bled after the onset of clinically significant portal hypertension, almost 20% of them decompensate within a year or two. But this all data has been extrapolated from pre-DAA era. From the post-DAA era, the natural histories get modified by the etiology, and only a recent study I could make out the patients of viral cirrhosis who were treated with DAA, almost less than 1% or less than 5% of them actually decompensated.
Dr. Gaurav?
So that's enough. No more questions. Pretty satisfied with the answers.
Okay. Thank you, Dr. Sanchit. Okay, bye-bye. So we can close the session here. The organizers are here.
Thank you, Dr. Sanchit. Nice presentation.
Thank you. You can log out, Dr. Sanchit. Yeah. So the organizers are there. Yeah, Dr. Amrish. So we can close this session.
Yes, a wonderful session, wonderful
Thank you.
presentations, and I hope we have gained some knowledge from this session. So now our next session will be on liver transplant hepatology course, and the course directors are Dr. Dinesh Jyotimani and Dr. Neeraj Saraf.
Just 1 minute, Doctor. Sir, shall we send the marks to you, sir, then?
I don't know, the marks probably we need to mail them, or Dr. Amrish? You send it by
mail them,
or...
but either way, sir. I'll send the format to you, then you can decide accordingly. And then,
So I think the format which I discussed with Kaushal was that we had to choose one out of them.
Yes, sir.
Right, but here there was only one person in at least,
Yes,
right?
Yes,
so he's
sir.
already chosen, yeah.
Yes.
So do we really need to mark him? Because is there a inter-group competition also? There was a group competition within the group between the two candidates.
Yes, sir.
And one had to be selected. Here it was only, one person who made two presentations.
Right,
so
sir.
is there an inter-group, which means is he contesting with the other groups also? Do we need to give him marks?
Sir,
Not sure, sir. They said
it was between the two. So here only one candidate was there.
Yeah, so he presented both. So I don't think he probably would need marks. He's already selected for the award.
Okay, sir.
Yeah, I'll just call up Kaushal and find it out here.
Sure,
Okay.
sir. Sure. Thank you, sir. Thank you so much. So nice.
Bye-bye.
Thanks, sir. Bye-bye.
Good evening, sir.
Yeah, hi, good evening. I think we'll start at 7:30.
Yeah, sir. There is some time left.
Yeah, so I think not everyone has joined also.
Good evening, everyone. Are we starting? Yeah, hi, good evening, everyone. This is a transplant hepatology course, liver transplant hepatology course. Welcome.
We'll wait for 2-3 minutes.
Yeah, I thought we'll just give some introduction to people who are listening so that the transplant hepatology is a very sort of upcoming specialty, particularly in India, where there are more number of liver transplants are being performed across various centers. So this is a little more than hepatology, and you have as a transplant hepatologist, we all have a much bigger role. So we thought we will get some session about transplant hepatology, mainly to the audiences who are listening. Are we connected yet, Chef Ali? And we not.
The starting time is 7:30, sir.
Okay, so probably we will wait for.
We just wait for another 4 minutes.
Yeah, sure.
Hello.
Yeah, can you hear me, guys? Okay.
Yes.
Audio visual team. Okay, so I have to share my screen, okay, for this session. Is that okay?
Akash, please help to share the screen.
We may as well set up the screen.
Yes, sir.
Hi, everyone. I can 90% of the people are hidden.
Yeah, hi, Dr. Sai.
Hello, sir.
Yeah. So, so can I share my screen, please?
Yes, sir. You can share your screen.
I'll just
share your screen, sir.
I'll just check it out here. That's all. You can see it nicely?
Yes, sir.
Okay, that's good.
Hi, Avi. Good evening. Good evening to all.
Hi, Sanjeev. Hi. What's happened? Stop sharing.
Hi, Dinesh.
Hi, Sharath. Hi, good evening. How are you?
Good evening.
Sanjeev, hi, Sanjeev. Good evening.
Hi, Dinesh. Good evening. Hello, Neeraj.
Hi, sir.
Hi. Lovely meeting everyone. I can see Prashant also, Neerav, all of you.
Hello, sir. Hello.
A great day today, India winning the Olympic gold.
Good evening, sir. Good evening, Sehgal sir, Puri sir, Dr.
Hi, Manish.
Prashant.
Good to hear you.
Good evening, Manish.
Hi, Manish.
Ideally, we should cancel this session and celebrate the gold.
That's true, sir. That's actually amazing.
I mean, everybody stopped doing everything they were doing. We stopped doing surgery for a few minutes. We were just kind of, watching him and replay and all that kind of thing. Anyway, no hepatologist, you don't have to worry. Everything is okay with the patient. So, right. So it's 7:30. So shall we get started?
Yes, yes.
Dr. Puri. Yeah.
So, do I start or somebody introduce?
Yeah, I'll just briefly introduce.
Okay. Yeah. Okay.
So, good evening, all. Welcome to liver transplant hepatology course. And today we have 4 important sessions. The first session is by Dr. Soin. I'm going to introduce the chairpersons, Professor Subhash Gupta, Chairman, Max Super Specialty Hospital, Dr. Neerav Goyal, Senior Consultant, Apollo Liver Transplant, Hepatobiliary and Pancreatic Surgery Unit, Dr. Manish Manroy, Professor, Medicine and Gastroenterology, AFMC, Pune. Kindly take over the session, chairpersons.
Thank you, Dr. Dinesh. I would like to invite Dr. Soin as the moderator for this session. He is the Chief Hepatobiliary and Liver Transplant Surgeon and Chairman of Medanta Institute of Liver Transplantation and Regenerative Medicine, Medanta, the Medicity. And I was fortunate enough to do my transplant hepatology training there with Sir and Dr. Sanjeev Sehgal and Dr. Neeraj Saraf. He is also the Group Chairman and Chief Surgeon of Liver Transplant Program at Jaslok Hospital, Columbia Asia Hospital, as well as GM Hospital, Coimbatore, and Medanta Hospital, Indore, NIMS, Jaipur, Siddhanta Red Cross Hospital, Sterling Hospital, Ahmedabad. Sir, I request you to start this session and invite the panelists for this session.
Thank you. Yeah, thank you very much, Manish. Some of those associations are old. We have some new ones and some old ones have gone. Anyway, thank you very much. So we have a very high-powered panel today. And we have Dr. Prashant Bangi, who's the Associate Director, Hepatobiliary and Liver Transplant Surgeon at Medanta, Sanjeev Sehgal, who's Chairman of Hepatology and I guess Liver Transplant Medicine at Max Hospital, Akash Shukla, who is Head of Gastroenterology, Professor and Head of Gastroenterology at KEM Hospital, and Akila Rajkumar, who is the Senior Consultant in liver transplant anesthesia and ICU at Rela Institute, Chennai. So we're going to talk about liver transplantation in a sick recipient. So we're going to actually have 3 case scenarios, and I'm going to ask questions of the panelists, and I request the panelists to take not more than 30 to 60 seconds in each of their replies. We have around 20 questions. And at the end of each case scenario, I will invite one of the chairpersons to make a comment. And all comments, including my own, should stay between 30 and 60 seconds. So here we go. So the first scenario is liver transplant in a sick ACLF patient who has sepsis, which is being treated, current AKI, and a recent history of COVID-19 infection. So this was a gentleman, 45-year-old, alcohol-related ACLF.
Soin, we can't see your screen. The screen is not shared, I think.
Oops, sorry about that. I did share it, but it must have got unshared for some reason.
Yeah, we can see it now.
Okay, thank you, Prashant. So Okay, so the first case was a 45-year-old male, alcohol-related ACLF with hepatic encephalopathy grade 2, had ascites, SPP. He presented with these problems. AKI with a creatinine of 2.6, lactate 1.7 at admission, and he had a blood culture from outside which said Klebsiella pneumonia, which is sensitive to meropenem. His MEL score at admission was 37, bilirubin of 22, INR of 2.4. You already have the creatinine. And the APASL ACLF research consortium score, which includes these 5 parameters, bilirubin, INR, HE, creatinine, and lactate, was 9. Maybe remind people that the cutoff of people who need transplant is 10. If it becomes more than 11, then I guess you have to wait to get them better. He also had abstinence for a very short period of 1 month, and he had recovered from moderate COVID with a CT scan score of 10/25 and had been hospitalized for 10 days and was discharged 1 month previously. So that's the case scenario, and we're going to ask our panelists their wisdom about several questions that arise in this patient. So Prashant, what would your plan be for this patient?
So obviously multiple comorbidities in terms of multiple decompensations and complicating factors in this patient. So I think number 1 is sepsis, because you've got a blood culture which is positive. Number 2 is renal dysfunction. So if you look at organs, sepsis, renal dysfunction, I'm not sure whether he's on inotropes. So, and you've got a chest which has just recovered from COVID, and it's a moderate COVID. It's a 10/25. So obviously you need to stabilize these patients in terms of the various organ systems first, sepsis being paramount, which he needs to come out of. And I guess that support for the sepsis in terms of antibiotics, along with probably the need for some renal support as well in terms of creatinine being 2.6 at the initial stage. So this patient requires some deal of stabilization before we can take on the next decision as to how to go ahead.
So how long would you wait?
So I think
this is him at presentation. How long would you wait? How many days or weeks would you think you would wait? Or is there no such period?
I think it would depend on the initial reassessment of the patient, as we have now come to this term that rather than a decision making at day 5 or day 7 or at 2 weeks, it is repeated reassessment of the patient probably every 72 hours to see how he is progressing. And my key factors for waiting would be number 1, sepsis. Number 2 would be to an extent the chest. So I think inotropes I'm not sure of if the patient is on. If
no inotropes. No inotropes.
So I think chest and sepsis would be the 2 main things that I would look at repeated assessment.
Sanjeev, you want to say something different from what Prashant has said in terms of your plan? Can't hear you.
Yeah. Okay. So the thoughts which Prashant has mentioned, I mean, they are very much, similar to what I would think. I mean, the waiting would be very cautious waiting, and sepsis is overwhelmingly in my mind when I am looking at this patient. And I really want to make myself comfortable with the sepsis part before I, consider him for transplantation. And he has got, 2-3 organ failures. So, and he's a very sick guy, 22 bilirubin. So we probably have to, really go beyond our, conventional rule. COVID, I probably won't be worried too much at this stage. But yes, if I am able to, convince myself that he's not having a fluid sepsis, blood cultures are fluidly not positive, maybe a 3 to 5 days reassessment would make it clear to me. And I mean, that would be, I think, the important factor. Renal part probably would not be an issue. I think that we can manage. And the most important factor which will again come to my mind is again it's the infective issues, which I would say. I'll also look at any fungal cultures and all, because that's something which often creep up post transplant.
Right. So I think the primary concern is sepsis here, and everybody agrees that AKI, which has just had a recent onset in such a patient, may not be a chief worry. Would you transplant this patient, Akila?
Yes, I think as we discussed, we'll have to reassess this patient and see how he does in 3 and 7 days time. If there is improvement and we are free of sepsis, I think we should go ahead and transplant him. He's young, and if he shows signs of improvement in terms of sepsis, we should go ahead and transplant. By day 7, yes.
So that's interesting. You say day 7 because it's been shown that whatever improvement or deterioration somebody's got to have, generally the grade at day 7 tends to be the grade of that patient. It can only get worse. It probably won't get better. It's a general feeling. But I mean, of course, individual patients differ. What about Akash? What is your feeling? Do you feel any differently, or would you agree with the fact that sepsis needs to be treated and you observe for 5 or 7 days, no more?
So we need to treat the sepsis. We need to correct the renal issues, AKI, SBP. But I would start counseling this patient for transplant right from the beginning, because very often we have seen that you get a very small window to transplant such patients, and the family should be mentally prepared when we reach that window before they get a second infection and they deteriorate again. So I think I would start counseling for transplant right at the beginning, but wait for the right window where the patient is completely free of infection.
Prashant, anything to add on this aspect? You didn't actually talk about transplant.
So I would agree completely with what Akash has said, and I would reiterate that point that don't delay it too much, because the counseling has to start initially, because otherwise when you have that window period, you are back to ground zero, where you don't have a donor, where you don't have the family counseled. So I would give it 5 to 7 days, and at day 5, day 7, of course, continuous reassessment, but at day 5, day 7, probably I would transplant.
Right. Sanjeev, so after 5 days, there is no SBP. HE is still there, creatinine is still 2.7, chest is X-ray-wise clear. But of course, we know that if you do a CT scan, you'll find previous changes of COVID.
Right.
And we don't have a repeat blood culture because the damn thing takes 5 days. So what do you do?
Yeah, I mean, actually, you're now giving those hints which are telling my mind to actually, take a call. And the fact that that he's not worsened too much, his SBP is not there, that's very reassuring thing. HE is probably okay. I'm fine with that. I'm again insisting that the renal part is something which is not going to stop me from taking a call if I have to do transplant. So this is a very close decision now. I wish blood culture were negative before I could have gone forward. And
so would you like to wait for them to come back, or you would be okay to proceed?
I mean, if his other parameters are not showing fluid, like signs of, a sepsis, like his procal, his, requirement for inotropes. You didn't mention inotropes. Is he on inotropes? That is something which is...
No, he's not. He's never
not.
been on inotropes. Yeah.
I think then it's like honestly, this sort of situation is, he's just giving me a window to take a call, and I might actually consider him.
So you are saying you're going to go ahead at this point, 5, 6, 7 days?
Yeah, I mean, see, he's just at the day 5, and accepting a blood culture which is not there with me. Most other things which you have shown me are actually allowing me to make my mind towards a transplant at this stage.
Okay. Akila, what do you think?
I think I would agree with him. It's not always possible to wait for a negative culture. The patient has shown signs of clinical stability. I think we should go ahead and transplant him. Kidney, again, we wouldn't be too worried. A patient with so much of a melt, we don't expect dramatic improvement without a transplant at this stage. So we can't wait to optimize the kidneys.
So everybody's saying by 5 to 7 days, once there's no obvious sepsis, go ahead. Doesn't matter what the creatinine or the mental status is. And Akash, tell us if you are worried about the recent COVID infection. Can't hear you.
So this has already been almost 4 weeks since the patient has been discharged. So there is no worry about active COVID infection. We would like to assess the chest with a ABG and a HRCT chest. And if the two are acceptable, I don't think that's a major hindrance.
Are you worried about PCR?
No, I would not even bother to do a PCR for this patient actually, 5 weeks after the original infection.
Right. So There you go. I won't waste time summarizing everything. I'm sure everybody participating has heard carefully. I would invite Subhash, Professor Subhash Gupta, just tell us your views on this case. Anything different, or would you like to tell us your policy?
I did want to say something important here. There's somebody who's just quit alcohol 1 month ago, and so it could be ACLF, it could be alcoholic steatohepatitis, we don't know. And if it's going to be alcoholic steatohepatitis, it's likely to improve. And a simple way of knowing that would be a cross-sectional imaging. They do an MR or a CT scan, tells you largely with a lot of fat in it. I would be inclined to wait because these people, alcohol steatohepatitis, that's the whole crux of ACLF when it consists of alcoholic liver disease. But yes, if he's had similar episodes in the past and he's not bothered and carried on drinking, then obviously he's a transplant candidate.
Right, thanks, Subhash. So he did have significant ascites. We assume that he probably has a good underlying good element of chronic liver disease. Okay, so
assumption really, isn't it? He's just quit alcohol 1 month ago.
Yeah, sure. I mean, I see what you're saying. His OTPT were in the 80s, 90s. And like I said, he had significant ascites and hypoalbuminemia, which I didn't say, of course. The albumin values were not given. So we're assuming this is like a barn door ACLF. Okay, so let's move on to the next scenario. A decompensated chronic liver disease with sarcopenia and poor performance status. So this is a lady who's 50 years old, is a diabetic who's averagely controlled, HbA1c around 7.5, non-alcoholic fatty liver disease, CTP MELD of 1222, diuretic resistant ascites, history of multiple LVPs, INR of 2.2, creatinine 0.8, bilirubin 5.6, 2 previous episodes of SVP, but none in the past 2 weeks. KPS, she barely walks to the bathroom with help. And she has a BMI of 17. She's all skin and bones. Serum albumin, 1.8 grams per liter. Sanjeev, reject or accept?
I'm bothered with that, very poor performance status, with KPS of 50. And I think that the thing which is going to be, inhibiting me from going forward would be her poor performance status. I think probably I'll reassess and rethink before I take up.
So you're not very sure that you'll transplant her. Okay, fair enough.
Yeah.
Fair enough. So, Sanjeev, we will come to some issues which you have been thinking of in a little while. So if we were to, let's say, Prashant, I make the decision for you, just for the sake of discussion, and that we were to do a transplant on this lady, what would be, in your view, important to do to maximize her chances of success?
I think two sides of the story. One is looking at the recipient, and number two is looking at the donor. In that way, two sides, and two sides also pre-op and intra-op. So I think in pre-operative period, number one, with a KPS of 50, a patient who is 12-22, I would build her up with nutritional support. Although it is not possible to get that nutrition up in some of these patients, but I would try my best to build her up with nutrition support, with albumin for a week, as well as enteral nutrition if it is required. Try to build her up in terms of her respiration, in terms of the chest, because that's going to be key in the post-operative period, and make sure that there is no sepsis. These are three things that I think in the pre-operative period I would do to get her to the best level possible before I actually take her for transplant. For transplant, she requires a good quality liver, a good quantity liver, and she needs a smooth operation. And I think these three things are very important, because if you have a huge blood loss during surgery and you have a difficult operation during surgery, which sometimes you can't avoid, but she needs to have a smooth surgery. And I would go ahead with her with a good antibiotic cover as well, because I think that these patients who are nutritionally compromised and who have, she's already had repeated episodes of SBP. I think that's something that is also important in these patients.
So would you choose to do a transplant, Prashant, prima facie, or like yes or no?
I would wait. I would wait for maybe 7-10 days to 2 weeks to try and build her up, because I don't think she's that sick enough also, if you look at her MELD and a CTP. And I feel that sometimes these people revert to some extent with better medical care and building.
So you would want to wait and build her up. Okay. Sanjeev, is sarcopenia important in these patients, and do you measure it in your patients?
Yes, I mean, sarcopenia is definitely important, and I mean, you say she's all skin and bone. So that just gives a picture of a patient who's really sick and not, having any reserve. As far as measurement is concerned, well, I mean, in the practice, we honestly don't follow that rigorous measurement and the indices, but it's more of an eyeball thing, and the fact remains that yes, sarcopenia with an extreme what you are mentioning here does impact the outcome in the peri-op, the post-op period, and certainly these patients need to be built up if there is a window of opportunity. If it allows me, I would do that.
So that's interesting. I mean, we all now know that there's enough evidence that sarcopenic patients do worse. And sarcopenia is measured in 3 ways. It's either muscle mass or muscle strength, or basically physical performance. Because, the end of muscle strength and muscle mass is obviously whether the patient is able to physically perform or not. So are there any simple tests that you think we should include in our protocols for these 3 parameters in patients who we suspect have significant sarcopenia?
I mean, one is this bedside, testing with the liver frailty index and all, which I think are fairly straightforward and easy. Actually, you can do it in a couple of minutes. I mean, the chairs stand, the patients, are like their spirometric, this thing. So they are not too much of a complicated thing. And, the hand dynamometry actually is very useful. It has been shown that if you are really following it, you can actually serially and objectively say that the patient is improved or not, if you have that. But in a practice, yes, we do clinical assessment, but we don't do it often from the concept of assessing sarcopenia per se. We do the overall picture, and we convert our whole assessment into a global one of these other KPAs, or one of those performance status scores, ECOG scores and all.
So good. So I think that Sanjeev agrees, and I think most people agree sarcopenia is important, and we could probably include measurement in some patients in whom we suspect sarcopenia, and grip strength, like you said, or simple walking, like performance.
The frailty index should be included, I think.
The frailty index is a mixture of sarcopenia and nutrition, probably. But yeah, that can be an indicator. So here's the question that all of you want to answer or want to have an opinion on. I would transplant straight away, since she has no sepsis, and she would improve post-LT, versus I would improve her nutritional and performance status pre-transplant. Is it really possible to improve somebody's nutritional status? That's the question. So anyway, all 4 of you, tell us, would you choose blue or would you choose brown? Would you transplant straight away or would you improve her status?
So I would just go one step back. If there is a recent insult or an event which has caused her to become worsened nutritionally recently, then I would improve her nutritional status and performance status pre-transplant. Otherwise, I think if it has been a gradual deterioration, I would transplant this patient straight away.
So that's Akash.
Yeah. I think for reasons that I mentioned before, also, I think that this patient, we wouldn't harm the patient waiting for a period of 2 weeks to try and build her up, given her current condition. And I think that she's had 2 episodes of SBP as well. So that again goes with the point that, it is possible probably she has decompensated and become worse possibly in the recent times. And I would give her 2 weeks to improve.
So Prashant will wait, Sanjeev will wait. You already said that. What about Akila? Would you wait or go ahead?
I think I will also wait. I'll also want to wait. Put them on aggressive nutrition rehabilitation and some home exercise therapy. It seems to work. We've tried it on a few patients.
So 3 against 1 on waiting versus going ahead. I'm not sure that you can improve somebody's nutritional status. Yeah. But yeah, of course, I think there is a point in improving their performance status and nutrition to an extent. If they've had recent deterioration, It's a fine call. What about Neerav? I'd like our chairperson to weigh in here. Tell us, what would you do for this patient in general, your views?
Well, sir, in such a scenario, we have a policy of waiting for about a couple of weeks, building the patient up nutritionally. Now, nutritionally build up doesn't mean that he'll gain body mass, he'll gain weight, but yes, intensive nutritional therapy for a couple of weeks. And we have seen that it brings down the mortality down to the same as that of other individual patients without sarcopenia. And yes, very important that surgery goes well and that not much of blood transfusions. So main thing is to build them up nutritionally, and that is what we also practice at our unit.
Thank you, Neerav. Thank you. So we move on to the third case now. Dual lobe versus low graft to recipient weight ratio, single donor in a sick, obese recipient. So the third case, a 48-year-old male, 125 kilos, BMI 41. He has HEV on NAFLD, ACLF. Peak enzymes a couple of weeks prior to when he presented were 1200, 1500. Now they're in the region 150 to 200. His MEL score at presentation is 29. He has moderate ascites, INR of 2.3, creatinine of 1.2, bilirubin 18, no HE, and an ARC score of 7. So, Sanjeev, would you, as the hepatologist in charge, recommend a low GRWR 0.65 graft, or choose, or back the surgeon in choosing a dual lobe LDLT, and why?
I think it's a very interesting situation, and I always think that this is a thing which is hugely center specific. I mean, we all would like to have a better GRWR, no doubt about that. And the fact is, the dual lobe is something which is, I think, center specific expertise, and not all centers are comfortable in doing it, as fluidly as many centers in, Korea and all. So I think that, well, I mean, conceptually, one would like to have a better GRWR. 0.65 is really low. What's the MELD of this patient? I missed the MELD.
29.
29. Yes, I mean, this is a high MELD patient with a low 0.5. We may, scrape through with a low GRWR if you're lucky. That's what I would say. But yes, dual lobe would be, something which I would really rely on my surgical colleagues. How much are they, comfortable in doing that in a sick patient like
So
this?
you prefer it if you had the surgical backup, right?
Yes.
Okay. Prashant, what's your view?
So again, I feel that probably two aspects. One is that he's a sick patient. A sick patient needs a good amount of liver, a good amount of a good quality and amount of a good working liver. This is number one. Number two is that he is ACLF. So if he is ACLF and it was initially A was HEV and the C was obviously chronic liver disease because of I think NAFLD. So there is a chance that this guy is going to stabilize a little bit more, as in you have a situation of acute liver failure and acute on chronic liver failure. I feel that an acute on chronic liver failure can wait for a period of 4 to 5 days, and those are those 3, 4, 5 days which you will require to actually evaluate and work up for a dual lobe LDLT also, which situation is sometimes not possible in ALF. So I think given the fact that number one, he is ACLF who requires a good quality, good volume liver, and you have 3-4 days which also are there for you to work up a dual lobe living donor liver transplant, I would go for a dual lobe LDLT in this patient for sure.
So Akila, if you were forced to do a low GRWR graft, any pre-transplant measures that you would recommend to enhance the success? Sorry, can't hear you.
He just messaged that he's having connectivity problems.
Okay. Let's do Akash's question, and then if you can connect, then we'll give it back. Now, Akash, would you wait for the HEV to settle and for the patient to return to pre-HEV status, or you think that's not going to happen because HEV obviously happened 2-3 weeks ago? What do you think?
Yeah, so for this patient, the enzymes have already settled and the patient appears to be worsening. And if the patient is worsening clinically, I don't think I would wait for the HEV to settle. I would take my next step immediately.
And is Akila back? No. So what are the pre-transplant measures to enhance chances of success?
So in this patient, the couple of things which I would be interested to know is if there is a significant amount of ascites, I would minus that. There are also papers which talk of considering GRWR with the ideal body weight and not take into consideration the amount of fat that is there. At our center, we are very comfortable with a GRWR of 0.65 for such a patient actually. So I would just optimize the patient hemodynamically, control the ascites, ensure that he's active, choose a good donor with a low, with minimum fat, a healthy liver. And I think with like Dr. Subhash Gupta's paper, a 650 gram, I think all those things, once we have ticked, I would be comfortable taking a low GRWR 0.65 graft.
So, right. So we have one person, so two for dual and one for, well, Prashant is clearly for dual. Sanjeev is saying that preferably dual. And you're saying single graft, low GRWR. Nobody talked about the donor risk of morbidity and mortality in a sick patient who may or may not survive. Maybe his chance of success are 80, 85%, not the 95.
See, if you
Is it worth putting two donors to risk?
Can I put a point?
Yeah.
I think that if you have a very neat graft which is non-steatotic, right? A good quality, and with from your surgical standpoint, you don't have any like anatomical problems. So you find it's a smooth operation which you can do, as an expert surgical this thing. I think that in that case, I mean, I would surely go towards doing a low GRWR and taking the call, because the exercise of dual would be too much extensive, and I think risk and all. And I think in that case, if it need grafts, non-steatotic is there.
So I don't want the audience to go back confused. So let's say that if the surgical team believes, number one, that low GRWR grafts don't work in high metabolic requirements, and number two, can conveniently do dual lobe transplantation and two donors are available, then since one donor will be right lobe, one will be left lobe usually, then I would personally do a dual lobe transplant here, and so would Prashant. And Akash and Sanjeev said single donor. Anyway, now a word from Manish as the chairperson. Where would you go?
Sir, it will depend on the center expertise, but definitely if the center has the expertise to go for a dual lobe transplant, I would actually tend towards that. It will all depend on the surgical expertise.
Right. Now, I think that we've kind of finished the questions that we had of the panels and the chairpersons. Is somebody keeping a track of the questions from the audience? I haven't seen any on the chat.
Yeah.
Okay, so then I hand over to the chairpersons. Why don't you conduct the discussion for the remaining 5 minutes? I believe we have 4 or 5 minutes left. Subhash, would you want to take over? Okay. Neerav?
I would like to ask something. See, we have gone down to as low as 0.45 also, with the single lobe livers doing very well. Basically, changes being made is the a splenectomy is being added in the recipients in such patients, because GRSVR plays a very important role, and we have seen that in our patients. So, in fact, a paper is getting published. I'll share as soon as it is out. And but based on certain equations like the graft to splenic volume ratio and the portal pressure, which is achieved at the end of the surgery, one can manipulate to a very low GRWR patient and still get same results as that with a high GRWR patients.
So are you saying that?
I know it's a bit off track from this discussion.
No, are you saying that you would do a low GRWR in this?
Yes.
Okay. Right.
I have a query for Dr. Sanjeev. Sir, regarding the first patient, I do agree that we don't need to wait for the cultures, but probably a trend of procalcitonin, probably if it's available, then if we have demonstrate a declining trend in procal, maybe that can give us a window of transplanting without waiting for a blood culture report. As Dr. Soin rightly said, we can't wait for cultures when the window is narrow.
Yeah, I mean, Dr. Manish, you have a point here, but I think, procal is too error prone. It's like not something which is very strongly, reliably, robust parameter. So I personally would not, give beyond a certain limit and an importance to it. I mean, my decision would be, not really depending too much on procal, frankly speaking.
And regarding the second patient where sarcopenia was an issue, it'll all depend on whether there is an acute precipitating event. If we can take care of the acute precipitating event, we can actually wait for longer than 2 weeks to transplant the patient, maybe stabilize, and because the outcomes in a sarcopenic patient is beyond the MELD sodium levels. So the mortality is higher in a sarcopenic patient, that is known. So if we can take off that acute part of the ACLF out, then probably we can actually get to a better level, maybe 2 weeks, if not maybe 3 or 4 weeks, provided everything else regarding the donor is worked up.
So here I need to step in to ask, what's the evidence that you can improve sarcopenia and nutritional debilitation before transplantation?
I just like to make a quick comment, if I may.
Yeah, sure. I invited you first, but I think you didn't hear.
No,
me.
I think I was muted at that time. I think in female, the sarcopenia index is never shown to be associated with outcome. That's some strange sort of data. It seems only to be correlated with male patients, the sarcopenia, for some reason. And I'm not clear what exactly the reason is, but the sarcopenia index does not, has not been shown in any of the studies that in females it actually affects the outcome. That was the first point. The second point that I wanted to make was that, unfortunately, even now, after so many years, there is no index that will tell you whether the operation is going to be futile. And we should actually work towards creating an index. Even in the sickest patient, you can have a very good outcome. And neither the MELD score correlates with it, nothing really correlates with outcome after surgery. And the third point that I wanted to make was about graft weight. And we've shown this elegantly, that doing a dual lobe transplant, once you have 650 grams, that it does not make any difference to the outcome. And we have sort of published it in clinical transplantation. And many of my colleagues agree with me, but they're too afraid to come out and speak in the open. They're still in the closet about this volume business. But anyway, I think Sanjeev's here, and he's seen us do lots of patients with 650 grams with so once you reach that volume, it's a kind of a sort of a, how should I, critical mass that
Sanjeev is not them. He's us. He's you. So
no, I'm there with everybody, and so, I did actually,
No, you can't.
You should comment on what you
Yeah. So this is a point which Dr. Subhash is telling is a very interesting point. Because I remember, this one of these patients I saw that obese guy who actually had a very low GRWR and was in fact had a COVID.
So guys, we need to close now. Yeah. Thank you everyone for your inputs. We're going to hand this back over to the organizers. And thanks very much for inviting us to do this. Thanks all the panelists and chairpersons and the audience.
Thank you.
Thank you.
Thank you. Thanks a lot.
Thank you very much.
Thank you.
Thank you, sir. Thank you. And we'll go over to the next session. And the next session is on kidney and liver transplantation. The chairpersons for this next session are Dr. Mohammad Rela, Dr. Kesar Raja, and Dr. Narasimhan. May I request? Hello?
Professor Rela is just sent apologies, unable to join. Dr. Gomati Narasimhan is there. I think Kaiser is joining, I think.
Dr. Jyoti, please take over.
Yeah. Neeraj, do you want to start?
Yeah, this session is a state-of-the-art lecture on kidney in liver transplantation. And the The speaker for this session is Professor Paul Martin. It's my proud privilege to introduce Dr. Martin, who's Chief of Digestive Sciences and Hepatology at the University of Miami. And he's been the editor of liver transplantation and is a very well-known figure in the field of transplant hepatology. And on a personal front, I trained with him and he was my mentor during my fellowship at Mount Sinai Hospital in New York. I think the organizers are to play his talk. It's already been sent and Dr. Martin will join us for the discussion.
Good morning, everybody. My name is Paul Martin, and I'm coming to you from Miami, Florida, USA. I would like to thank Dr. Saraf and his colleagues for the opportunity to speak to your association today. I'm going to talk about the important issue of the role of the kidney in liver transplantation, which is an area of increasing
We can't hear the voices.
Akash, please check.
Research and I think also some controversy. My disclosures pertinent to this presentation are that I've acted as a consultant for Mallinckrodt. And what I hope to do today is give you an overview of evolving concepts in the management of renal dysfunction in patients with more advanced cirrhosis. Clearly, renal dysfunction is common in patients with advanced liver disease. A number of different entities are identified, and these can include hepatitis C-related glomerular nephropathy, alcohol-related IgA nephropathy, diabetes or hypertension-related kidney disease, which is obviously increasingly important now that we're seeing more patients with fatty liver. And then finally, both in acute and chronic kidney injury, we're paying close attention to the emergence of new concepts in the management of hepatorenal syndrome. In a patient with acute kidney injury, this can also be pre-renal. It can reflect acute tubular necrosis or exposure to nephrotoxic medications. But most of my presentation will be related to hepatorenal syndrome. Now, in the natural history of the progression of portal hypertension, there are a number of important events. These include the development of varices, the onset of ascites. With time, many patients develop refractory ascites, are prone to recurrent variceal bleeding, and these are typically the patients who experience hepatorenal syndrome, as well as other major complications of their liver disease, including recurrent hepatic encephalopathy. And all of these translate into an increased mortality risk from liver disease and its associated complications. In patients with cirrhosis, kidney failure is common, and a number of series have described a high prevalence of acute kidney injury in patients admitted to hospital with cirrhosis. Once patients develop ascites, 20% or so will develop hepatorenal syndrome within a year, and taking it to a later stage of the liver disease, 80% of patients with cirrhosis and refractory ascites develop kidney failure. And as I mentioned already, fatty liver patients have multiple additional risk factors for kidney disease. Very importantly, kidney failure predicts mortality. Creatinine is a powerful driver of the so-called MEL score. And then finally, there are unique and severe forms of kidney failures recognized in cirrhosis, namely hepatorenal syndrome. Not infrequently, patients will have a number of episodes of worsening renal function. This study looked at 90 patients with cirrhosis who had an apparently normal serum creatinine at onset. And in this series of 90 patients, 49 had episodes of acute kidney injury. Now, very importantly, even though these episodes in most cases appeared to resolve, what happened was that the patient ended up with a higher creatinine following the episode, even though it may have remained within what was regarded as normal for the hospital laboratory. But once a patient had had an episode of acute kidney injury, even though they apparently recovered, their mortality was increased substantially. Now, what is the pathogenesis of renal dysfunction? This is multifactorial. A number of processes are in play. With the development of cirrhosis, there's obstruction to portal flow, which in turn increases the shear stress on portal vessels. This may facilitate gut bacteria translocation. In turn, this may lead to release of vasodilator substances. There's splanchnic vasodilatation with a reduction in the systemic blood flow despite increased portal inflow. And generally, there's a hyporesponsiveness to vasoconstrictors. And in addition, there may be increased mesenteric angiogenesis. Other mechanisms come into play. With a reduction in the effective arterial blood volume, a number of compensatory mechanisms are brought into play, including an increase in the cardiac output, which over time may encroach on the cardiac reserve, and also activation of various receptors in the kidneys, which are sensitive to changes in blood pressure. And this in turn leads to the production of vasoactive substances. The net effect over time, however, is a reduction in GFR and renal blood flow, which in turn stimulates sodium retention, setting the stage for renal failure. Looking at hospital series, acute kidney injury was recognized in a large number of these individuals, in these patients who were described from a number of major centers. Now, the definitions varied, but a substantial number of these patients were recognized to have hepatorenal syndrome. But importantly, there were other causes for acute kidney injury, including hypovolemia and acute tubular necrosis. Now, typically, we rely on the serum creatinine to define the presence of kidney injury. But very importantly, it has some limitations. Creatinine can take days to reach a steady state after injury. Up to 50% of kidney function can be lost before creatinine starts to rise. It reflects perfusion, not injury. Creatinine is a poor estimate of kidney function in cirrhosis because it's impacted by diet, muscle mass, muscle metabolism, low liver production of creatinine, hydration status, and medications. And also, there's some concern that bilirubin and other substances have a variable impact on creatinine measurement depending on assay and calibration. So this is a somewhat imperfect measure of renal function in patients with and this in turn has led to concerns about its role in the MEL score, because patients with low baseline creatinine are disadvantaged. And this is particularly marked among women who typically have a lower muscle mass and thus a lower serum creatinine at baseline. There have been a number of attempts to counteract this imbalance, and one of the more recent papers from Dr. Ashrani in Dallas is to use the so-called MEL-GRAIL sodium score. So in essence, instead of you relying on the serum creatinine, this is an estimated GFR, which incorporates a number of parameters, including creatinine, age, gender, race, and serum albumin. And this is felt to be a more accurate predictor of true renal function in patients with this. Now, the definition and diagnosis of renal dysfunction, liver disease, has continued to evolve. So I think there are a number of important points, and the most important one is probably it's the change in the serum creatinine that's probably most useful in trying to detect the early stages of acute kidney injury in these patients. So we tend to rely on a baseline creatinine, and then the definition of acute kidney injury in this paper from about 6 years ago included a rise in the serum creatinine of at least 0.3 milligrams per deciliter in less than 48 hours, or an increase in serum creatinine from baseline, and then the severity of the decline in renal function was divided into 3 stages. So again, what may seem a relatively modest rise in serum creatinine may have very important prognostic significance in patients with underlying cirrhosis. Now, more recently, these criteria have been further defined. So the diagnostic criteria include the presence of significant liver disease, including cirrhosis, acute liver failure, or acute and chronic liver failure. And it also continues to include an increase in serum creatinine greater than 3 milligrams per deciliter within 48 hours, or greater than 50% from baseline, and or a decline in urine output. And no full or partial response after at least 2 days of diuretic withdrawal and volume expansion with albumin. The recommended dose of albumin is 1 gram per kilogram of body weight per day to a maximum of 100 grams per day. So I think the important thing in this set of diagnostic criteria is that the decline in renal function is first suggested by a decline in urine output. So I think most of us tend to wait, or at least I do, for the serum creatinine, but I think what we need to do is pay more attention to the urine output, which can be difficult in a hospitalized patient who's not catheterized. The diagnostic criteria in this newer reiteration include an absence of shock, no current or recent treatment with nephrotoxic drugs, absence of parenchymal liver disease as indicated by proteinuria, microhematuria, urinary injury biomarkers of available or abnormal renal ultrasound, and a suggestion of renal vasoconstriction with a reduction of fractional excretion of sodium to less than 0.2%. And to further increase our sophistication in the management of these patients, the old term hepatorenal syndrome type 1, which is the more rapidly occurring form or evolving form of hepatorenal syndrome, has now been replaced by the term hepatorenal syndrome acute kidney injury, where again we see this absolute increase in serum creatinine and or a decrease in urinary output, or a percent increase of at least 50% in serum creatinine using the last available outpatient value within. And again, this is this definition. So I think the important thing really is the increase in the serum creatinine over a short period of time. And again, the new classification, the hepatorenal syndrome type 2 has been replaced by a number of other terms, including hepatorenal syndrome acute kidney injury, but very importantly, hepatorenal syndrome chronic kidney disease, where there's been a decline in renal function for at least 3 months in the absence of other explanations, such as a urinary obstruction. And again, the timeline is important, and in particular, if a patient has had diminished renal function for 3 months or so, it's unlikely, even with successful liver transplant, that the renal function would recover. Now, how do we manage renal dysfunction in patients with liver disease, particularly in the cirrhotic. Now, there are a number of important interventions. Obviously, if there's any suspicion about acute kidney injury in a cirrhotic patient, they require close monitoring. Again, particular attention to urine output. Remove or minimize risk factors, and this includes removing NSAIDs, minimize nephrotoxic drugs, reduce or withdraw diuretics, treatment of infection if present, and volume expansion with albumin. And I think another important thing not to do is to order a contrast study in a cirrhotic patient whose renal function is already somewhat tenuous. If the patient responds to volume expansion with albumin, hopefully the acute kidney injury will resolve, and those patients obviously require continued close follow-up. If there's progression, more intervention is probably going to be required. And if the renal function is diminished but appears stable, the patient requires a continued close follow-up. And again, I would avoid the temptation to reintroduce diuretics, or at least high-dose diuretics. If the patient has more advanced acute kidney injury, again, it's crucial to withdraw the diuretics. There is no role for a trial of Lasix to induce a diuresis in a patient with possible hepatorenal syndrome. Patients also require adequate volume expansion. Again, if they respond, they require close continued follow-up. Now, if the patient does not respond to these interventions and meets the criteria for hepatorenal syndrome, there is now a role for the use of vasoconstrictors and albumin. If it's felt that the patient has another explanation for acute kidney injury, management will be dictated by the etiology and possible options. Now, albumin continues to play an important role in the management of renal dysfunction in patients with cirrhosis. So above and beyond its oncotic capabilities, it may have a role in immune modulation, endothelial stabilization, decreased capillary permeability, and like a lot of things these days, it may also be an antioxidant, and it can lead to an improvement in renal dysfunction, at least some patients with cirrhosis. And very importantly, when it's used in patients with acute kidney injury and a background of decompensating liver disease, it's important that the patient receives an adequate dose of albumin. This study several years ago suggested that there was a dose-response curve. And again, a patient needs to have received adequate albumin before it's deemed to be a failure. And very importantly, adequate albumin in this study translated into improved. Another intervention is this is a paper that appeared several years ago, which suggested that beta blockers were deleterious in patients with clinically overt cirrhosis with ascites. So I think they need to be stopped, obviously, if pressors are started. And I think if there is evidence that the patient is developing renal insufficiency, such as hypotension, elevated creatinine, or low serum sodium reflecting ineffective water clearance, I would also tend to stop. Now, what is the role of constrictors? Terlipressin, which unfortunately is not licensed in the United States, has been an important adjuvant in other parts of the world to the management of renal dysfunction in patients with cirrhosis. It's a synthetic vasopressin analog, and it's a number of benefits, including reducing the splenic blood inflow and thereby portal pressure. It redistributes part of the intravascular volume to the central circulation, and unequivocally improves renal function in patients with hepatorenal syndrome. And very importantly, treatment with a number of different interventions which results in improved hepatorenal syndrome, results in survival. In the United States, we're dependent on midodrine and octreotide for hepatorenal syndrome, and in this study, terlipressin was clearly superior. This is a study that was published in the New England Journal of Medicine within the last several months, and in essence, it was addressing the use of terlipressin with albumin in patients with hepatorenal and it was able to demonstrate reversal of hepatorenal syndrome. It had a number of secondary endpoints. The fewer of the terlipressin patients required renal replacement therapy even after the drug study was complete. It appeared to be particularly efficacious in patients with systemic inflammatory response syndrome, and there was a trend, but it was not statistically significant, that there was less recurrence of hepatorenal syndrome by day 30. It doesn't cure the underlying liver disease. What it does is and very importantly, it also suggested that patients with hepatorenal syndrome who underwent subsequent liver transplant required less frequent renal therapy. To summarize what I've discussed so far, if a patient has hepatorenal syndrome and are being assessed for liver transplant, it's appropriate to start renal replacement therapy if there's no response to vasoconstrictors. But again, I think the management needs to be defined ahead of time before a patient is placed on indefinite dialysis if they're not going to be a transplant. And here are currently accepted criteria for a combined liver-kidney transplant, which has been an important strategy over the last several years in the United States. And in essence, it's reserved for patients who've been on dialysis for at least several weeks, who are anticipated not to experience recovery of renal function. And there's also more recent literature suggesting a role for initial liver transplant followed by subsequent renal transplant. And indeed, we've seen an increase in the number of simultaneous liver-kidney transplants in the United States since the introduction of the MELD algorithm. There are a number of potential benefits. It appears that the liver protects the kidney from rejection, shown in a number of papers here. So just to summarize, renal dysfunction, liver disease onset is key event in the progression of cirrhosis. It identifies cirrhotic patients at a high risk of mortality. Vasoconstrictor therapy enhances management of hepatorenal syndrome, may reduce post-liver transplant renal failure, and there's an important but continuing to be redefined role for combined liver-kidney transplant. So thank you again for inviting me and giving me the opportunity to participate.
Okay, thank you, Dr. Martin. And I would invite the chairpersons for this session, Dr. Gomati Narsimhan and Dr. Kesar Raja, to take forward the discussion.
Thank you, Dr. Thank you, Dr. Paul. It was a wonderful overview of renal dysfunction and cirrhotics and the pre-transplant phase. It's always a very challenging situation when patients have got borderline renal dysfunction, creatinines between like 2 and 4, who are not yet on dialysis, and then we take them up for liver transplantation with the hope that the renal function would improve in the post-transplant period. So are there any specific strategies which you would advise in the pre-transplant period, like the 48 hours before and after transplant? I know terlipressin is not there in the United States, but in our country, a lot of centers tend to use terlipressin perioperatively. So you have any views on that, or any of the strategies which we would use to protect the kidneys in the peri-transplant period?
Yeah, well, thank you again for inviting me to speak. I just had the excruciating experience of listening myself for 20 minutes, so I apologize, I seem to fade in and out. But I think the most important thing is to avoid any nephrotoxic insults in the immediate pre-transplant period, and that includes close attention to fluid balance, avoiding interventions such as contrast studies unless they're absolutely crucial. And again, I thought one of the most intriguing pieces of data from this study from New England Journal of Medicine is the use of terlipressin may have reduced post-transplant renal failure as implied by the requirement for renal replacement therapy. And as I also mentioned in my presentations, there are a number of urban myths that persist, at least here, that somehow giving IV Lasix is sort of a trial by error in a patient with tenuous renal function. It's not. It's going to make the renal function worse if the patient has a hepatorenal syndrome. So again, I think first of all, do no harm is the most important strategy peri-transplant. And then I think post-transplant, you can modulate the immunosuppressive regimen to avoid nephrotoxic medications, for instance, delay the introduction of a calcineurin inhibitor.
Thanks, Dr. Martin. That was a very, very interesting one, even for a surgeon like me to go through the medical bit of it. But I mean, in terms of the criteria for a combined liver kidney, would it vary if you have two live donors as opposed to the patient being listed for a deceased donor as to when you would do the, would it be simultaneous or sequential?
Well, one of the challenges is that we're better at identifying in retrospect which patients needed a combined liver kidney versus a liver transplant alone. And now in the United States, I didn't get into it in the interest of time, the organ allocation system assigns some priority to patients who've had an isolated kidney or liver transplant rather, and who develop renal failure post-transplant and end up in dialysis. So those patients get priority for access to renal donors in the few months following liver transplant. I think there are a lot of variables, as you well know, but I think intraoperative events affect renal function post-transplant. If it's an unusually difficult operation, if the patient has a protracted or delayed graft function afterwards, et cetera. So I think those are all factors you may or may not be able to mitigate, but I think giving the patient the best donor possible is also part of the strategy. I'm not sure if I exactly answered your question.
Can I ask a question? I'm Dr. Sharath here, a hepatologist practicing in South India. The burden of kidney disease is actually very high in this part of our country. Now, a lot of times as a hepatologist, we are called upon to give an opinion on a patient who is going for a kidney transplantation, who apparently has portal hypertension and ascites, but the liver function is otherwise very well preserved. So the question that is asked of us is whether kidney only would suffice or whether they need a kidney and liver transplantation. I find that decision making very difficult. I mean, the patient classically is a child's A cirrhosis. The ascites could be more due to the kidney disease rather than the liver disease. And with a very compensated liver function, we are placed in a very difficult position to recommend simultaneous transplantation. In this scenario, would you be comfortable recommending a kidney only to these patients?
I think the more information you have about the patient, the better. And in addition, obviously, to determining whether or not they have varices, I would also do transjugular pressure measurements, which have important prognostic role. And so if the patient has a gradient less than 10 millimeters of mercury, I would certainly be comfortable in advocating for an isolated renal transplant. As you also implied, the ascites needs to be adequately characterized. If it reflects portal hypertension alone, that patient, I think, is going to struggle with an isolated renal transplant.
Thank you.
Okay, I think we are running out of time, and we'll end this session here. I thank the chairpersons for chairing this session, and thank you, Professor Martin, for joining in on a Saturday morning, and thank you for your wonderful talk.
Okay, thank you.
Thank you.
Okay, we'll move on to the next session, which is a very interesting session on liver transplant pathology. And this is on cholestasis 3 to 6 months post-transplant. So this is a case discussion. And to chair this session, the chairpersons for this session are Dr. Pankaj Puri, Dr. Sharad Putta, and Dr. Amit Rastogi. And the discussants or the moderators for this session, the pathology discussion would be by Dr. Mukul Vij, and the clinical discussants are Dr. Manav Vadhavan, Dr. Dharmesh Kapoor, and Dr. Joy Varghese. With this, I hand over to the moderators and the chairpersons to carry the session forward.
Thank you, Neeraj. With your permission, can we start with my co-moderators, Dr. Dharmesh, Dr. Joy, chairpersons? Can we straight away start the session?
Yeah.
Please start.
Okay, so let me share my slides first. So we have a specific situation here. We have a patient who's been transplanted around between 3 and 6 months and has now developed cholestasis at least 3 months after transplant. So luckily we had a case like this, and I've taken up that live case to bring home the point, and we'll try to discuss through this how we went ahead and approached this patient. So this was a 47-year-old male patient, underwent a disease donor liver transplant for alcoholic liver disease in January 2021. This was not at our center. We all know in Northern India, we hardly do any disease donor liver transplant. So in January, end of January, he underwent a disease donor liver transplant. The donor was impeccable, good liver. The patient had an uneventful post-op recovery and was discharged on day 12. Standard triple immunosuppression was followed, and steroid was tapered to 5 milligram by May 2021. So he was on 5 milligram of Vicelon, omnacotil, but when he developed the dysfunction. Now in June, this was the beginning of June, he started having itching and he noticed that he has yellow eyes, and he reported to the primary center. And at that time, he did not have any fever. So this was the last liver function test at which his steroid was tapered to 5 milligram, bilirubin of 0.5, enzymes were normal, alkaline phosphatase was normal. And this is when he presented back to his primary hospital with a bilirubin of 8.4 now, enzymes are more than 3 times raised, ALT is 157, AST is 132, and even alkaline phosphatase is 3 times the normal range according to the primary unit. This guy was at that time asked, a few investigation was asked for, and he was asked to report back in the OPD with those investigations. In the meantime, his tacrolimus was jumped up. I'll tell you that he did not have a TAC level at the time of presentation. Her TAC level was asked for, and he was his immunosuppression was doubled, and the steroid was made 20 milligram. And 4 days later, he presents with a bilirubin of 38. Enzymes are reasonably in the same range. Alkaline phosphatase is further up. We don't have a gamma G. So can I ask my co-moderators to pitch in here? Dr. Dharmesh, Dr. Joy, what would you think this guy is developing and how would you approach it? What would be your differential diagnosis?
I think this gentleman is not been transplanted at your center, and people who get transplanted at other centers, one of the commonest things that one must bear in mind is whether the donor workup was complete. So oftentimes the anti-core total is not done in many centers still. So that is something that always finds favor with us. So here you won't have the donor sample with you, but at least you should do on the recipient. We should take history of drug default. He was transplanted for alcohol use disorder. He should be clerked with the family member. And we should make sure that his pill counts and all those things are in order. The approach, and if given that everything is in order and we are not talking of any hidden agenda here, he would first be subjected to, like you said, a CNI trough level, which has not been made available. I would not bump up his steroids without knowing what is going on. So I would not make that 5 into 20. I would just persist with that, get a good imaging done, make sure that the plumbing job was well done, and there are no problems with the various issues that can come up between 3 to 6 months. Most importantly, the biliary issues. So because this is a deceased donor graft, and I would assume that he's been engrafted with the whole liver, it was not split. And the biliary issues, I would not say they don't exist, but they are certainly less common in the deceased donor setting than in the living donor setting. If this patient was in the living donor setting, it is not unusual for the radiologist to report oftentimes subtle IHB are seen, or something they will mention which will just confuse the issue. But in deceased donor, the biliary issues are, one can be more dogmatic in defining them. And then, of course, what is going on with the blood vessels, including the inflow, the outflow, the hepatic artery, Doppler signal. This patient has walked into your OPD, does not have any accompanying signs. I'm not saying that he could not be septic. He's still on a low dose of steroids. So the usual screen, the chest X-ray, the white cell count, the inflammatory markers, the urine examination, all of those things would be done. And I find rather unusual the jump in the bilirubin. So that is something which has taken me quite by surprise. So that is something which one would find extremely difficult to explain. I don't know whether the value that you got of 8 was a wrong value. So that is something that I would take with a pinch of salt.
So I agree with you. So this guy, his core antibody, the information we got was negative. There was tested for HBs antigen, which came as negative. The recipient recovery was excellent after transplant, and his LFTs are almost normal throughout. So he completely denies the history of alcohol intake, including his family. So it's not recidivism that we definitely know. So the primary unit did viral markers, which came as negative. CMV DNA was done, which came as negative. Procal was normal. His TLC was normal. He did not give any history of fever. A Doppler showed impeccable vasculature. The artery, the portal vein, the hepatic veins were seen very well. The unit went ahead and did a MRCP and a liver biopsy. And this is what the MRCP looked like. Joy, any comment on the MRCP film?
So it shows slightly the narrowing, but there is no proximal much dilatation compared with that. So mostly it's a DDLT setting, the direct duct to duct anastomosis is time. So mostly it will be normal. And if this compared with the LDLT means scenario different, but the DDLT scenario, if you are looking into that, there is a chance of the slight narrowing is there. We have to rule it.
So this is very common in very common in MRCPs that you see this is a vessel crossing the bile duct and you get a flow void. So that is the reason why you see this kind of a pseudo stricturing. So I would just pass it off as normal. So even if you were to tell me that this patient's bilirubin has jumped to 38 because of a stricture, I would shoot that diagnosis down.
Absolutely. I completely agree. It is very, very unusual for a biliary stricture to cause a bilirubin of 38, but that's what you and me think. The primary unit did not think so. What they diagnosed was a biliary stricture, and they went ahead, did a ERCP. The ERCP reported a stricture at the anastomotic site. They said they have removed CVD sludge and they placed a 10 French into 7 centimeter double pigtail across it. Interestingly, the bilirubin, which was 30.
Yeah, so here I wish to convey, because whenever the 3 months after post-transplant, if they are getting the stricture or CBD, the slide, mostly sometime it will be the biliary cast. So the biliary cast mostly will cause, sometimes there is, this DDLT, the ischemia to the biliary epithelium will cause the cast formation. So that also we have to keep it in mind. That time we have to see proximal urinary also.
Yeah, but vasculature.
Fair enough. We didn't see a cast in the MRCP, and the ERCP also didn't talk about the cast, but your point is right. A cast can lead to cholangitis also. It can give rise to bilirubins, which are quite high, but 38 again is quite difficult to explain. Now this guy, 3 days later, his bilirubin decreased from 38 to 33, enzymes slightly improved, but the diagnosis of biliary stricture was shot down by this. On 20th, he retrieved the stent in his stools. So if the stent is slipping out after the primary ERCP, I would presume it is not a stricture. I don't know what you think about that, but that's my primary thing. That's what how I would take it. A stricture does not let the stent pass like this, and the bilirubin went up to 40, and the patient was not well. Any thought from the chairperson? Amit, any comments?
I think you're right that such a high rise in bilirubin, there can be partial narrowing, but it has to be associated with something else. Just the stricture will not explain. And then there is mild improvement, but not significant. So probably the stricture is less likely. Plus, with such kind of bilirubin, the alkaline phosphatase could have been much higher. So I agree with the discussion going on that stricture could be a incidental finding. We completely do not say that it is just vessel on the thing, and we'll have to respect the radiologist. But I agree with Joy saying that there is only central dilatation and not peripheral. So stricture will lower down in the list.
Fair enough. Fair enough. So that's when the primary unit went ahead and did a second liver biopsy. Sorry, a second ERCP, and they placed this time 2 stents. So they were sticking with the diagnosis, and you look at the liver function tests here. Bilirubin goes up to 47 here now. The patient is still not septic. His PLC is normal. He's on antibiotics, and obviously his immunosuppression would have been held while undergoing the ERCP. And that's the time when they do a second liver biopsy. Can I request Dr. Mukulvich to upload his slides and show us the biopsy?
But we have not seen the first biopsy. Manav, we have not seen the first biopsy.
So I'm coming to that. Actually, the first biopsy and the second biopsy were similar. That's the reason I chose not to discuss the first biopsy. The reporting was similar.
Okay, can you see my screen?
Yes, sir, we can see your screen.
Yeah. So we will go through these biopsies. So this is the first biopsy, and what we can see, these are portal areas. We can see these portal areas, and there is some inflammation here, predominantly lymphocytic inflammation. These are the bile ducts, which are showing some degenerative changes. You can see that nucleus, you can't see nucleus here, so there is disturbance in the nucleus polarity, and also in the lumen also there is disturbance, inflammation, not significant endothelitis in this portal tract, inflammation and some ductulitis. In this tract, there is very minimal inflammation, occasional ductulitis, and no significant venulitis. In other portal tracts, now this is at least moderate inflammation, moderate plus inflammation. You can see ductulitis here. Again, extensive degenerative changes in the bile duct. You can't even see a lumen here. Here, there is some endothelitis is also happening, and there is some spillover of inflammation from the portal area into the adjacent periportal parenchyma. We can see that there is disturbance of the portal stromal interface, portal and parenchymal interface. In this portal tract, again, there is mild inflammation. This is a ductulitis and mild venulitis you can see. In other portal tracts, again, inflammation, some ductulitis, minimal venulitis here also, but all the ducts, whatever ducts we are seeing, they are showing extensive degenerative changes. You can see vacuolization also here. There is degeneration, vacuolization here. Again, this also disturbance of polarity, and lumen is narrowed here. And not much venulitis here. Here also we can see ductulitis. So inflammation, ductulitis, and some mild venulitis here and there. In this portal tract, again, there is less inflammation, but injury to the bile duct, atrophic bile duct here and here also. In occasional portal tract, what we see, there is no duct. There is a vein here, there is an artery here, but you cannot see any bile duct, and there is no inflammation here in this portal tract. In this portal tract also, there is vein. There are 2 veins. There is an arteriole, but no duct. So there is focal duct loss also. And you can see some bilirubinematosis here, some ballooning, some cholestasis here, mild lobular infiltrate, occasional spotty necrosis. And C4D, there is complete absence. There is C4D is negative. And CK7, most of the ducts are identified with occasional absence of duct. More than, I think, 15 portal tracts were there, and occasional duct loss was there in CK7. So with these findings, I will go with features of late T cell mediated rejection. On the background, there is also start of early chronic rejection with duct dystrophic or dysplastic changes.
Dr. Mukul, which were the first biopsy and the second biopsy, or they are all mixed?
This I am talking about the first one. The first one. Now we go to.
No, second biopsy we'll discuss later. This is the third one actually. The biopsy which I have provided you is the third one. Let me just share my screen. Dr. Mukul, if you can take off your.
Sorry.
So the patient underwent 2 biopsies at the primary unit. The first biopsy and the second biopsy were identical. That's the reason I chose to send only the first biopsy slides to Dr. Mukul, and that's what it showed, a late acute cellular rejection, which was not treated primarily, and the stricture diagnosis was made and treated. The patient worsened. Subsequently, after the second biopsy, the same findings are found in the second biopsy also, and the patient got 3 doses of solimetrol. But despite getting 3 doses of solimetrol, his bilirubin is static from 46 to 47 to 46. Enzymes are same, alkaline phosphatase is rising, and that's the time when the patient decided to take a second opinion and came to us. So this is definitely a difficult to treat rejection, what we are dealing with. Now, the interesting thing is that if you look at the inflammation, the RAI, Dr. Mukul, this will not be more than 4, I believe, out of 9 or 5. Or 5.
Yeah, 4 to 5, yeah, something like that. Yeah, around that. Yeah.
But he's got some bile duct damage. He's got late
yeah.
acute cellular rejection. He's got a bilirubin of 46 without any biliary issues, without any sepsis. Dr. Varghese, what do you think is happening? This guy why is he having this high a bilirubin if the inflammation is not significant? And we can see bile duct in most of the tracts.
That's why I'm also surprising, because whenever the high bilirubin is there, in the liver biopsy wise, it has to show hepatocanalicular cholestasis. But whatever Dr. Mukul showed the images, it shows only the inflammation. There is no hepatocanalicular cholestasis. Really, I mean, Dr. Mukul, can you explain? Is it possible without hepatocanalicular cholestasis, the bilirubin level will be such a high?
No, there is cholestasis. In the last slide, there is some lobular cholestasis. It's going on.
And you showed some tracts which were not having bile duct. So I think these are quite significant biliary damage. And this TCM are probably the bile duct damage.
Yes.
It's the overwhelming.
He's going into early chronic, so it's looking like that.
And I think the only thing one would want to say at this stage is that we do not know what is going on with this background immunosuppression. So when you have got allograft dysfunction, at times even with very modest dose of CNIs, you can get extraordinarily high levels, and these patients rapidly go into renal dysfunction because of that. So when you have either sepsis or renal dysfunction with background TCMR, you can have very high bilirubin values, which are not all because of the liver damage, but because of the other things which are happening in the background. So those are 2 other things that I would want to really pay a lot of attention to.
So I'm glad, Dr. Dharmesh, you raised that thing. So this guy actually had renal dysfunction exactly the same way as you have described. His TAC levels jumped to 18. He was on mycophenolate, tacrolimus, and steroid. After the steroid bolus, they were giving something like 40 milligram of prednisolone, but his tacrolimus level was 18. His bilirubin had gone up to 2.2, which may be partly explaining why the bilirubin is so high. And secondly, there is significant bile duct damage. This guy is going on to a chronic rejection with some significant activity. So that's where we are. There is no AMR here. There is no antibody-mediated rejection. We did not see any plasma cells. So it is not even a plasma cell-rich rejection. So we are possibly dealing with the early chronic rejection with a acute component. What would you do?
Dr. Manav, can I ask you all a question that how common is it to find the first biopsy showing early chronic rejection and do not have acute rejection in the past? I mean, generally they would.
That is very strange. And interestingly, this is a guy who is very particular about maintaining his record. So I saw his record from January to May. The last LFT available was May, and his enzymes were in the range of 1.2, 1.5 times normal. And bilirubin was always normal. It was very surprising for me also.
It's not unusual. So there are many people who, mostly for financial reasons, they would continue to take their immunosuppression, but not in the manner that you would want them to. So this is not unusual. So something that, see, we all know that you can have a TCMR with normal liver functions. We all know that. And it's mainly the histological injury that is going on. And then whenever this person realizes that yes, something is amiss, he will again start to take it. So it is not always a must that you should have sequential episodes of either partially resolved TCMR or an untreated TCMR and then only progress to. So I would still not call this chronic rejection. He's showing changes of biliary senescence and some portal tracts not showing the bile ducts. But Dr. Mukul, would this qualify for a definition of chronic rejection? I think it would only be a TCMR with some biliary senescence and or progressing to a chronic rejection, early chronic rejection. Probably that is how you would describe it. Or is there some other terminology you would use?
No. The thing is that with TCMR also we can see duct changes because a lot of inflammation. But when you see in the portal tracts in which got very minimal inflammation, but those ducts also shows disturbance of polarity, eosinophilia, and vascularization, that suggests the background of chronic is developing.
So he came to me. I thought we should again investigate for AMR. I did a donor-specific antibody, which obviously we didn't have the donor, so we did an anti-HLA-1 and 2 antibodies, which were negative. A repeat liver biopsy, would you do a repeat liver biopsy before you plan treatment here? Because this guy, after the second biopsy, he's got a steroid bolus, and we don't know what is the current situation. So how many of us would do a repeat liver biopsy, and how many would straight away proceed to whatever we want to do?
So I think this patient has been shoddily treated, and I would do a liver biopsy more for reasons of whether one would want to hammer him with the steroids or not. So generally what happens in difficult to treat rejections is that once you've given them one session of the bolus methylprednisolone and you find that the liver enzymes are not settling and the graft function is not coming back to normal, you do the second biopsy, you find that the second biopsy is quiescent. So you do not see much by way of inflammation, but there is ongoing cholestasis. That is the general picture that you would see in patients who are not typically going to respond to steroids, after which you would do whatever you would want to do. So if I find that in the repeat biopsy, there are more portal tracts which are devoid of bile ducts, I would be very cautious. So if this patient is going into frank ductopenia, at that time to heighten their immunosuppression would be disastrous, because then you would kill them very quickly. So if there is the kind of picture that you see, which Dr. Mukul has described in the biopsy that he did, yes, I would still be comfortable to treat him differently, modulate his immunosuppression by whatever would be the units policy. It could be an mTOR inhibitor, it could be an IL-2 receptor antagonist, blah, blah, blah. But if I find that most of the portal tracts are not showing bile ducts, then I would just take a step back and start tapering his immunosuppression. The other things to bear into mind would be whether he started to develop portal hypertension, which is again not unusual. Very commonly, these patients start to develop ascites. And if you find that the renal dysfunction is not settling even by you modulating his CNIs and ruling out sepsis, then again, one has to be extremely cautious in modulating the immunosuppression. So these would be the considerations.
So what we did was I drastically reduced his Prograf, his tacrolimus, because his level was 18 and his creatinine was 2.2. So from a 4 milligram twice a day, I came down to 1, and I added a small dose of everolimus, repeated a liver biopsy. Dr. Mukul, can you discuss the liver biopsy? The third liver biopsy this time.
Manav, can I ask Dr. Dharmesh a question? Suppose in such a situation, or in cases where you fear that there is early chronic rejection, will the addition of everolimus or other immunosuppression not help? Some studies say that even early chronic rejection can be helped by.
So that's what I said. But you should, yeah. So you should know what we are dealing with. So if this patient, in spite of the TAC levels coming down, the renal function continues to remain abnormal, or he starts to develop ascites. These patients develop ascites very quickly. They can develop ascites in less than a week. So that is the situation in which one has to be very careful. And if in the subsequent biopsy, Mukul tells me that now whatever portal tracts he is seeing, there are no bile ducts in that, then at least I would not be very keen to hit him with anything else. But if he tells me that only the inflammation is quiescent, but I don't see more dropouts by way of biliary epithelium, even though of bile ducts, even though the bile duct epithelium might still be abnormal, then yes, surely I would treat him. So that is
Sure.
what I would do.
Dr. Mukul, please.
Yeah. So this is the liver biopsy. You can see two portal tracts here. This is the lobular area, this portal tract, and there is definitely reduction of inflammation in these portal areas. You don't see much of inflammation. Architecture is maintained. You can see some cellular swelling here. Now, in these on these portal tracts, you see there is an arteriole. The duct look extremely dysplastic now. You can see this enlargement of the nucleus. It's looking like a dysplastic duct and dysplastic duct, some venulitis and significant decrease of inflammation. Here also, you can see this duct. It's completely, you can't see the lumen, extensive dysplasia in these ducts and minimal inflammation. Now, all these portal tracts are like this. You can see, here you can see vein and arteriole. I don't know, there is no duct here. In this one, again, I think there is necrosis of duct happening here. You can see extremely eosinophilia. Only one nucleus here. This is like the duct is going to be dead after some time, and there is minimal inflammation. So inflammation definitely has reduced from last time. Here also we don't see duct and no inflammation. Here we see duct with dysplasia, no lumen, and minimal inflammation in all of the portal tracts. Here again, dysplasia. Here you can see cellular swelling here, some inflammation in the lobule, in the perivenular area. Again, duct loss. In this portal area, there is duct loss, occasional arteriole and vein only. There's no arterial loss. Now, extensive ballooning and cholestasis. You can see this cholestasis in the calanicular area. In the macrophages, you can see bile, and also there is ballooned out hepatocyte. You can see this bile pigment in these hepatocytes also. Here also, you can see some cholestasis in the perivenular area. And there is some necrosis also starting around the perivenular. You can see this area, some congestion. So say they start of some necrosis also here. And again, cholestasis, you can also see some necrosis here. So all these things suggest that now he is progressing. It's like early chronic because there is no diffuse duct loss, but he is definitely progressing into he will progress to ductopenic rejection. Looks like that. It's progressing because inflammation is reduced.
Can you unshare a slide, sir? I'll go back to the original presentation. I'll just take a few more minutes now.
Manav, can you wrap it up soon? Yeah.
Yeah. Just one more minute. So this guy still has, so his chronic rejection is progressing. He's having more ductal loss, but the inflammation is persisting. So what we decided was that we should treat this guy. I would be wary of using ATG in such a patient because the inflammation has significantly reduced. But there is still some ongoing inflammation. I thought we'll give him a chance. We started him on basiliximab. You can question the decision because inflammation is less, the ductal loss is more, but we gave 2 doses as scheduled on day 1 and day 5. And his bilirubin now starts decreasing. On day 8 of the first dose, from 46 to 25, goes further down to 11, and the last report is 9.6. In the meantime, his gamma GT has been increasing consistently, and interestingly, now he's developed small amount of ascites. Now, I don't know where he's going to go from now. This is a very recent report which I'm showing you. But we were able to get his bilirubin down from 46 to 9.2. The patient is looking well. The ascites is mild. I have not started him on diuretics. I'm just trying to build up his nutritional status. I'll end here and invite any comments from moderators and chairpersons.
I think this patient will get better. Just keep him on low dose of CNIs. Don't use diuretics. Diuretics almost never will help in this situation because he's on now corticosteroids, everolimus, anti-metabolite, and CNI. You could modulate the dose of all of them, and just keep him on only very modest CNIs. So this is not unusual. Most of the time, this gamma GT is reflective of regenerative change. It's very commonly seen. In this cohort of patients, you can have even in 4-digit enzymes. That's not uncommon at all. And of course, once they develop ascites, you have to bear in mind that, with the immunosuppression, whether there is a CME, viremia that comes into play. So all these things would, fungal infections, respiratory infections, all these things we have to pay due attention to. But I think this patient has probably gone over the fence now. He should recover. But I still can't explain that 8 to 38. So I think there is that error in that 8.
There may be some error in the initial report.
So
it's possible. It's possible. That's what he came with. That's what he came with. So I've shown that report here. But yeah, I agree with you. It may have been 18 or something. Or for whatever, all you know. Thank you. Thank you for patient listening. Thank you.
Manav, just one quick comment. So I think chronic rejection is not as uncommon as we think, and we do see it, and it's something we should look out for. We published a series of 20 patients 2-3 years ago of chronic rejection or early chronic rejection, and 50% of them responded to everolimus. So I think everolimus plays a very important role. And for some reason, 50% of these patients had past history of biliary stricture. So there is some association of, biliary injury with previous biliary strictures with chronic rejection, which really I don't know the explanation.
So Neeraj, just to make a quick comment. So you are talking mostly of the living donor setting. So living donor setting, I know Dr. Amit is there, so you can almost never vouch for an absolutely adequate biliary drainage. So this is something that I have said on many fora, that patients who have got living donor transplants, they end up getting more immunosuppression. And whenever you find that these patients are then symptomatic because of their biliary pathology, they undergo interventions and you dramatically reduce their immunosuppression during that period. So what you are saying is absolutely right, but you will not see this phenomena in deceased donor transplants.
Yeah, but
so,
I disagree with you a little bit that, that's the explanation generally given, that you decrease the immunosuppression. But I don't think as a center we have not been doing that. But there is still some association of, it's not that the immunosuppression was decreased and that's why these patients went into rejection. Anyway, I think we'll end now, and I'll hand over to Dinesh to carry on the next session.
Thank you, guys. It was a wonderful histology session. Thanks, Manav, Mukul, Dharmesh, Dr. Amit. Yeah. So the next session is keynote address by Professor James Newberger. It says his profile is consultant physician at Queen Elizabeth Hospital, but his profile is much, much more than that. He's a chair of NHS Blood and Transplant. And to chair the session, we have Professor Sudhindran from Amrita Institute and Medical Sciences, Dr. Chandan Kumar, consultant hepatologist from Hyderabad, and Dr. Charles Panikal, Aster Medicity from Kochi. So I would like the chairpersons to take over the session, please.
Thank you so much, Dinesh. It's such a pleasure seeing all the previous discussions. So I think without further ado, we should get Professor Newberger to talk about liver transplantation, long-term management. I think he has been in this business for a long time. He should be the apt person to tell us about it. Professor Newberger, the guys is yours.
Okay, well, thanks very much indeed for the invitation. I've enjoyed the talk so far. I'm only sorry I can't be in India in person because I do love it. But one of the advantages of doing this, I can watch the cricket results, and I can tell you that England are now 248 for 6 in their second innings, and that's 153 ahead. But as you know, India has an innings to go, so it's all to play for once. So thanks very much for the invitation. I'll get on with it really. I'll try and share the screen. I hope it works.
Yes, we can see it.
You can see that. Okay.
Yes.
So
can you make a slideshow, please?
Can
you make a slideshow, please?
Yeah. Okay. So thanks very much indeed. The message really is there's nothing clever about long-term management. It's all a matter of attention to detail. I've got no relevant disclosures. And the first point I want to get across, this is a paper from the States showing really that there's been no gain in long-term survival after liver transplantation.
Sorry to interrupt, it's not exactly a slideshow. It's come like the speaker's notes.
Oh, sorry, I've got slideshow on my...
Oh, is it? All right, okay, fine. Okay, carry on.
If you're happy with that. And there's been no advantage in there's no improved survival really over the last 3 decades in long-term survival. And there you can see the UK data, which we've recently looked at, which shows that of those patients who survive 6 months or indeed 90 days, results overall survival has not really changed very much. So the surgeons are improving, the physicians really have got a long way to go when looking after the patients. So the first point I want to stress is that results are not great after transplant as they should be, and we're still no better than we were 30 odd years ago. As you can see, the life of a transplanted patient, shown in this sort of light, in greeny color, is in the blue, is significantly less than that of an age and sex match control. So patients are not living longer; they're still dying prematurely following transplant. If you look at the cause of death, this is a slightly old study, but it's still one of the best I can find. It looks at the cause of death post-transplant. And as you can see, recurrent disease, and of course that was mainly hepatitis C, and to a lesser extent B, which are far less of a problem now, infection, malignancy, renal failure, gastrointestinal complications, cardiopulmonary failure are all major problems. Graft failure is not a major problem. And here, if you break it down a little bit more, this is an NIDDK study. Again, you will see that infection, cardiovascular disease, malignancy, and renal impairment are major factors. And on the right-hand side of the screen, you can see that those factors increase over time. Now, the other point I'd make in this story initially of gloom is that the quality of life in these patients is also less good than in an aged and sex-matched control. So physicians looking after the long-term health of patients have got a significant way to go. It does tend, as I say, this just expands the quality of life. It does improve, but there remains significant impairment and different psychological factors, depression, anxiety, problems with sexual function, employment, maybe domestic issues are all important. And I think the clinicians need to be aware of these, and in particular, mild depression, although requiring treatment, and anxiety should be inquired for. And again, sexual function is often impaired after transplant. It's probably largely unrelated to the transplant or its treatment, but again, asking about it can allow interventions that help the patients. So, in summary then of the first bit, survival rates are not improving. But one point I would make is that the age of patients we're transplanting is increasing. And of course, as you increase in age, you increase the risk of renal failure, you increase the risk of cancer, you increase the risk of heart disease. So when you're looking at the increased risk of patients, you need to look at the standardized incidence ratio, i.e. see if recipients have a greater risk than the normal population. So we need both the absolute risk of, say, getting heart disease and the relative risk, so seeing what we can do to intervene to reduce that complication. And the main causes of death are, as I said, cardiovascular disease, renal failure, some infections, some de novo malignancies, recurrent disease, and immune-mediated graft damage. These are largely modifiable, so why aren't we doing better? These are just, I've chosen these, it's typical of many papers showing from 2 non-transplant centers, there was incidence of renal failure on the left-hand side, increasing with time, up to 10 or 15% by 20 years, which is really quite depressing. And that's largely, but not totally, related to the immunosuppression and the use of calcineurin inhibitors, the incidence of cardiovascular events, and as you can see, they tend to increase too. So quite a few problems. And if you look at the increased risk, again, these are our own Birmingham data, that the relative risk of a cardiac event is increased threefold, both of cardiovascular events, that's predominantly strokes and heart attacks, but also death from cardiovascular disease. So a significant problem here that we need to address. There are many factors that predict that, and obviously age, cardiac disease, post-transplant, diabetes are all major factors, as you might expect, diabetes too. Part of the problem is to look at the metabolic disorders, and as you can see here, this is a summary, and it's interesting how kidney recipients have data very similar to liver recipients, and you can see a significant number of patients post-transplant have metabolic syndrome, they have new onset diabetes, of course it's higher in those who are hepatitis C positive, and it's related to tacrolimus, they have abnormal lipids, and they have hypertension. And it suggests it's not the liver disease or the indications for liver disease, because the renal patients have broadly similar risk factors too. So the first key point is there's nothing clever But to treat the diabetes with the conventional drugs and aim for the conventional targets with an HbA1c, sorry, this is old speak, of below 7.5%, to get the lipids back to acceptable levels and to treat hypertension aggressively so you get a good value of 130/80. Calcium channel blockers are probably the first line over the renal artery, over the RAS, I'm sorry. They're probably the best ones to use, but most patients seem to require combination therapy. The glucose lowering agents, again, the standard ones are all, the rules apply, but do be aware that some of these newer drugs one has to avoid in the presence of renal impairment. Again, there is an interaction with cyclosporin with some of these too, so you need to be careful which sugar lowering agents you use. But again, there's nothing specific to the transplanted patients, as I say, apart from the increased awareness of drug-drug interactions, particularly with cyclosporin. Weight gain is a major problem, and all centers are seeing this. This is just our Birmingham data. And as you can see, the weight, the BMI increases over time in all patients, and those who are overweight or obese prior to their liver illness are also more likely to get obese after their transplant. So yes, immunosuppression does have a role, absorption has a role, but behavior has a role. And as I say, those who are obese post-transplant, but pre-transplant, are likely to become obese post-transplant. There is no magic cure for this, no simple treatment. Bariatric surgery certainly has a role in those with morbid obesity, and although the data is somewhat confusing, it is no doubt that in selected individuals it's both safe and effective. Whether one would want to do bariatric surgery or other forms of intervention during the time of transplant is an issue for another day. One factor I really want to stress is the use of statins, and this I've taken from a recent review with a meta-analysis. And as you can see, yes, statins after transplant do have side effects, and the adverse reactions of myopathy and myalgia and nausea and vomiting are rare, but they do occur. But when you look, and I'm sorry this is not entirely clear, in the bottom right-hand corner, you can see that there is an impact, statistically surprisingly, on both graft rejection and recurrence of HCC. This has been confirmed in several studies. But more importantly, there has a significant effect on both cardiovascular events and mortality. Therefore, you really got to think of early introduction of statins I think all adult liver transplant recipients. I think they're underused. Immunosuppression, I'm not going to say a lot about because there's a whole talk about that. The number of papers, I did have a graph showing the number of papers talking about tailored immunosuppression, is greatly talked about. Many people lecture, few people listen because it's rarely practiced. And of course, you want to maintain a minimum effective regimen, and there is no clear way of assessing that. There are various biomarkers proposed, but none of them really are sufficiently robust for clinical use. Again, I'm not going to talk about immunosuppression withdrawal. I think the evidence now is very safe if done properly, and a significant minority of patients can successfully develop operational tolerance. So think about it. I think the question is, when most patients are given usually a tacrolimus-based triple immunosuppression, when do you switch? I think with ongoing renal impairment. Now, when should you switch with renal impairment? Again, there's very little data on which to base that recommendation. I would say round about a GFR of 60, but again, when we looked at our own data, it's very variable, the response. What would you switch it to? Well, either sirolimus or everolimus if there's no proteinuria, or major surgery planned, or the woman is not going to conceive. Prednisolone and azathioprine, again, the old hands. I was brought up on prednisolone and azathioprine as immunosuppression. It is very effective. The only difference in the studies between azathioprine and mycophenolate is the incidence of neutropenia is far higher on mycophenolate and the cost is far greater. Otherwise, they're very similar. And the other reason for change was mentioned in the earlier talk is some malignancies may respond better to sirolimus or everolimus. Non-adherence is something else that you need to consider, particularly with the younger patients, and surprising, at least in the renal transplant population, non-adherence is greater in recipients of living donor kidneys than deceased donor kidneys. That may be impact of age, family dynamics, or whatever, but it does seem to be a consistent but minor effect. There are many ways you can identify a non-adherent patients, but again, as was briefly alluded to in the last talk, some patients don't take their medication reliably until they're coming up to having their blood tests. So always think about non-adherent patients. And this was a very nice study from Sabine East looking at non-adherence across all organs. And as you can see, the number of non-adherent patients is reasonably high pre-transplant, it falls post-transplant, but over time it rises, and the liver patients have a reasonably high incidence of non-adherence. Of course, whether non-adherence means not taking any immunosuppression or taking it occasionally, it's very variable, but do always think about non-adherence, check it with the patient. The risk factors I've mentioned, cost and side effects, in my experience, are probably the most common ones, and particularly with steroids. Excuse me, but do remember to look for that. The other point I want to raise is the importance of de novo cancers. The risk of de novo cancers increases with time, whether they're skin cancers or non-skin cancers. There have been a number of studies looking for this, and this just shows again the UK data I was involved with, and this is the SIR. So you will see, for example, for liver, that breast cancer, as indeed for most other organ transplants, is not increased post-transplant. And therefore, yes, the female recipients should undergo cancer screening, but that does not have to be increased. The main increase, of course, is skin cancer. Cancers like Kaposi's, like lip and anus are increased, but of course they are extremely rare cancers in themselves. Alcoholic, do de novo cancers affect outcome? Yes, they do. This is just one review a couple of years ago from the zoo in +1, again showing that both men and women who have de novo cancers have a lower survival. So we do need to be much more aware of these and screen as appropriate. Surgical complications, causes of late allograft loss, again, were discussed. And these are some of those, in particular, recurrent NASH. Hepatitis E is now being increasingly recognized, and we know that although this usual course of hepatitis E is one of acute hepatitis, in those who are immunosuppressed, chronic hepatitis and cirrhosis is well recognized, and the best way to test for this is with RNA rather than IgM or IgG antibodies. Other components you can read there, and immunosuppression, both under immunosuppressions we've discussed, and both T and B cell rejection has been talked about. So this is slightly out of order, I'm sorry for that. Improving the outcome from de novo cancers, to monitor the patients, encourage them to stop smoking, avoid excess sunlight, not always easy. Surveillance in high-risk groups, particularly colonoscopy for those with known colitis, and routine imaging in those with alcoholic liver disease, where we know the risk of lung cancer and upper GI cancers is significantly increased. Skin surveillance is important, although there's no good evidence that I'm aware of that having a dermatology review every year or 6 months actually affects the consequences of skin cancer. Minimize the immunosuppression burden and consider switching to sirolimus or everolimus in selected cancers. Now, as far as the graft health is concerned, it's important to remember that normal liver tests does not mean a normal graft, and equally abnormal liver tests do not mean a disease graft. Protocol biopsies, I think of voice in the wilderness here. I'm a great believer in protocol biopsies, but these have been largely ignored. Very few people are doing these, primarily for logistic reasons, and of course with the recent pandemic there have been far greater priorities on the use of hospital beds. But we did a survey of about 200 or so protocol biopsies with liver tests that were normal, and what we found was, protocol biopsies, that liver histology was normal in a quarter of the patients. Chronic hepatitis, whatever that is, was present in a third, and it did allow us in those with normal histology to reduce the immunosuppression, and equally in those with inflammatory disease and rejection, we increased the immunosuppression. So it does allow better management, and we're seeing, particularly in the pediatric population, an increased risk of fibrosis in the graft. What that's due to and what it represents is not clear, but I think we need to be aware that when we're looking at 30, 40, 50-year survivals, particularly in the children, graft fibrosis may become something to worry about. The role of FibroScan, I think, is going to be increasingly important, but the data are not yet sufficient to justify its routine use. But I think it really is helpful, and we ought to be using it more. I don't want to say too much about apparent disease. Viral hepatitis, you'll know a lot more than I do about the modern treatments. PSC, we've got no real treatment for that. Alcohol, and I'll mention the others in a minute. As far as alcohol use is concerned, return to alcohol or use of alcohol in those transplanted for non-ALD is an issue, and it does affect graft survival and indeed patient survival. You can monitor it by asking the patient, by asking the relative, by measuring blood or urine alcohol, but probably the most sensitive and specific one for any alcohol use is to use either phosphatidylethanol or scalp hair ethyl glucuronide. CDT, carbohydrate deficient transferrin, is of low sensitivity and specificity, so I don't think it offers very much. Urinary alcohol metabolites, again, is of help. So I think we could be a bit more proactive in looking for markers of alcohol and advising patients accordingly before they get irreversible graft damage. I know that PBC is not that common as an indication for transplantation in India, but I would like to draw your attention to this review by Corpushow and colleagues that was published last year, a retrospective analysis of histologically confirmed PBC. And what they found was that preventative exposure, that's from the time after transplant to ursodeoxycholic acid, reduced the risk of documented PBC recurrence, reduced the risk of graft loss, reduced liver-related death, and indeed all-cause death. The effects were statistically significant, but relatively modest, 2.25 years over 20 years. But again, if you're one of those people who gained an extra couple of years, that's probably a good thing. The other point that I would stress from this review is that treatment with cyclosporin rather than tacrolimus also had a beneficial effect in addition to that of urso in reducing PBT recurrence. So again, we ought to be thinking about managing these patients on both cyclosporin-based immunosuppression and urso. One final thing, I think one couldn't let a day go by without talking about COVID. I think vaccination, the response is less than immunosuppressed. And as you know, attenuated and and live vaccines should be avoided. I just thought I'd give you these recent data from the UK experience of COVID vaccination. Of 6,500 patients who hadn't received even one dose of vaccine, 7% developed COVID and 40% died, with the UK definition died within 28 days of a test. Now you compare that with the 39,000 who'd received both doses of vaccine. Fewer than 1% contracted COVID, and of those only 8% died. So although the response in vitro to the vaccine may be less effective, it's certainly worth offering those recipients transplantation. Now, my whinge at the start was there's nothing clever about following up these patients. It's a matter of attention to detail, looking at risk factors, intervening with tobacco, with weight, with smoking, with alcohol, looking at liver and renal function, adjusting the immunosuppression. Checklists, I think, are very valuable. And this is some data from the New England Journal showing that the introduction of the WHO checklist had a significant impact on the outcome of patients undergoing surgery. And you can see the data quite clearly shown there. And indeed, there was a reduction not only in infections, but complications, but also death. Now, this was a randomized controlled trial, so checklists do seem to work. I was very skeptical, but I think the data is quite clear. And we have introduced with conjunction with Fujisawa some time ago, a checklist that people could use so that every time they're seen in clinic, that a pro forma is filled asking the pertinent questions. This not only provides a useful record, which should of course be computerized, but also make sure that all the issues are addressed, that you're checking the blood pressure, checking the weight, checking the immunosuppression, checking graft function. So in conclusion then, longer term outcomes after liver transplant are not really improving significantly. The surgeons have done their bit, the physicians have still got theirs to do. Major causes of premature death and graft loss can probably be reduced, as I say, probably because there's no firm data, by close attention to lifestyle, particularly obesity, smoking, alcohol, immunosuppression, treating medical conditions actively, particularly hypertension, diabetes, hyperlipidemia, and monitor for and act on non-adherence, de novo cancers, and renal impairment. So thank you very much indeed for your time. Thank you for the invitation. And if you're still awake, thank you.
Prof, thank you so much for that. You be pleased to know that England is still on the 6th wicket, so we're okay. So thank you so much. I think we face pretty much the same problem as you do, because our predominant problem has been, as you rightly said, diabetes, weight gain, and cardiovascular problems. Diabetes is a major issue. My own experience is more than 50% actually get new onset diabetes, respective whether they're on steroids or not. One question I had, Prof, was what do you do for patients with renal failure or renal impairment who do have proteinuria? What do you do with them? Because
if they've got proteinuria, then I would not put them on sirolimus. So my normal practice is when the renal function starts to deteriorate, round about 50 to 60, then I'd discuss with them switching. We've had to defer that because of COVID. We don't want to bring them up too frequently for blood tests. But what I usually do is to stop them on sirolimus. If they tolerate that well without side effects, proteinuria and so on, then I gradually withdraw the calcineurin. If they've got more than 2 classes of proteinuria, then I'd usually start on, despite my rude comments about mycophenolate, I usually start with prednisolone and mycophenolate, trying to run them on something like 7.5 of pred and a gram BD of mycophenolate, and take them off cycles. The response to that is variable. But as I say, porolepred and myco for those who are renal impairment with proteinuria. Obviously, one has to look at other factors, renal disease, diabetes, hypertension, and all that sort of thing as well, and overuse of diuretics. But if you think it's calcinuria related, I think stop it before it becomes too irreversible.
Thank you very much for that. Are there any other questions?
Yeah, this is Prof. This is Sharad. I have a couple of questions for you. Good evening. Thanks for the great talk. Should, along the lines of alcoholic patients having to show 6 months of abstinence, do you think there's a case for people with metabolic syndrome, poorly controlled diabetes, who may have behavioral issues, who need to show that they're going to be compliant with therapy? And is there a case for maybe turning down somebody who is in their late 60s with a poorly controlled metabolic syndrome?
You've touched on a very interesting ethical dilemma. I think alcohol and obesity and fatty liver disease from overweight have many things in common. I mean, they both have significant genetic effects. They both have psychological effects. Nobody chooses to be grossly, or very few people choose to be grossly obese. Very few people choose to be alcoholic. It does have extra hepatic manifestations. So I think there are a lot of other similarities too. I think the answer is you probably have to go towards the middle of both. We've gone away from the 6 months abstinence, and I think we have to encourage those who have eaten themselves into liver failure for whatever reason, to encourage them to control their appetite. But it is very, very difficult. I don't think one ought to deny people transplantation because of either alcohol or obesity, but one does need to put measures in place. And I think there is an argument for early intervention with surgery. And I've read with interest the reports of doing bariatric surgery at the time of transplantation. Is quite heroic, but that may be an option. And I think one needs to address as much resource into the obesity side as we do into the addiction side. But I think the answer is probably we need to have a common course and be sympathetic to both groups.
Thank you, Prof. Am I allowed to ask one more question?
Yeah,
carry on.
Prof, how do you identify the set of patients who might actually be more immunotolerant than the average transplant patient, and how do you choose the patient where you might completely take off immunosuppression long term?
I'm outside clinical trials. I'm still reluctant, but if patients are keen to do that, or I think they're going to be non-compliant, then to reduce immunosuppression, I would do a liver biopsy. I think those who are more than 5 years out are more likely to be tolerant. Those who were not transplanted for autoimmune disease are more likely to be tolerant. But I think I would discuss it with them and do it in a very controlled way. There have been a few graft losses, but I think as we understand the process now, it's a lot less. I think the molecular signatures, and there's a lot of work on those patients, they're not yet ready for clinical use. So I rarely do it unless the patient's very unhappy. And then to some extent, if you do start immunosuppression withdrawal and they have an episode of acute rejection, it's quite good because it emphasizes to them the need for long-term immunosuppression.
Thank you. Thank you.
I think in the absence of any further questions, we can end the session because Professor Newberger wants to watch India-England match, so we can let him. Okay.
Thank you so much, Prof. Such a enjoyable talk. Thank you so much.
Thanks, and thanks for the invitation. I'm sorry I can't be there in this body.
Thank you, Prof. Very
Thank
nice.
you.
So I just summarize the day, and it's been a fantastic evening. Thank you for all the speakers, chairperson, panelists, and so I thought I'll just quickly summarize from the first 4 talks. The timing of liver transplantation in a sick patient is very, very crucial. You should not miss the window of opportunity. At the same time, when they're septic, we should not offer transplantation. When there's a chance to improve the nutrition, we should offer them to improve the nutritional status, because it does play a major role in the post-transplant outcomes. And also monitoring graft function in the immediate post-transplant period is very important, first 3 to 6 months. They may have biliary issue, they may have different types of rejections. Therefore, we should then maintain optimal immunosuppression and maintain the balance of sepsis and immunosuppression. I would think probably in our country, sepsis is more common than rejection episodes. Therefore, liver biopsy is crucial in certain ways. And definitely it's a multidisciplinary approach. We should discuss most cases with the pathologist actively. Other thing is kidney plays a major role in liver transplantation in patients with end-stage liver disease. I would say that managing renal function is a holy grail of patients with end-stage liver disease, particularly when it comes to the post-transplant outcomes, actually. And Professor Neuberger spoke beautifully about long-term management of liver transplant recipients. Lifestyle modification is a key issue. So physical activity, optimal nutrition, adherence to the medication, not overtly immunosuppressed, keeping very, very optimal immune suppression in the long term, and preventing them from getting infective or non-infective long-term complications are crucial. So I would like to thank all the participants, all the questions that were put forward. On behalf of INASL, thank you everyone, and we'll end the session.
Thank you, Dr. Dinesh and Dr. Neeraj, for a very exciting session. And we look forward to seeing you all tomorrow. Tomorrow we have a very exciting day as well. In Hall A, we'll have the Young Investigator Awards, as well as we'll have some case-based discussions on ACLF and complications of cirrhosis. Hall B, the highlights will be the clinical practice of hepatology today and tomorrow, as well as a pediatric hepatology course. And Hall C will have clinics in hepatology and some highlights of the recent guidelines which have come forward from INASL. Thank you, and look forward to seeing you all there tomorrow. Have a great evening and see you all tomorrow.
Good night. Good night.
Good night. Thank you.